the introductions. Single एक करके अच्छा होगा ना.
अरे she has not come. प्रेमलता को फोन लगाओ.
We are live now.
Okay. So, before the formal welcome by Professor Dr. Rajiv Gupta, sir, we welcome you all today for the yet another educational activity of Jharkhand Ophthalmological Society, which is Jhos third PG training program. And this is very important because this is on the subject of cornea, which needs to be understood more. And we have selected the topics, those topics on the cornea, which can be of immense practical value to the PGs, like scraping, like dry eye testing, which is done mostly by the postgraduate students and optometrists. Foreign body removal, because these are also done mostly by the students. So this is of immense value, and I please request all the PGs to switch on the camera. Despite my repeated request, I kept only see Dr. One CCL PG, and the faculties are only there. And Professor Rajiv, I'm connecting Dr. Professor Rajiv Gupta for formal welcome. So Dr. Rajiv Gupta's mother is very sick. He is in Patna. So, and Dr. Madhu Uttaraju is joining soon. So Dr. Rajiv Gupta is connected now. Wait. Please, PGs. I can see my PG, Samir. So Professor Gupta, hello, sir. Sir, बोलिए. Hello? Sir. Hello, sir. Yes, sir, you are audible. So please give the welcome speech. Yes. Yes, sir.
He is not audible actually.
Yes, you are audible, sir. Yes, you are audible. You are audible, sir. You are audible. Yes, yes. Good morning, good morning. फोन करो उसको, बुलाओ, प्रिंट आउट मांगो, प्रिंट आउट. तुम लोग दिख रहे हो. Thank you, sir. Thank you so much. Thank you so much for your kind introduction. And it keeps us inspired because you are heading the largest PG training institute. So thank you, sir. Thank you. So now I request Dr. Mitra to introduce Jhos speaker. And before, when the guest faculty will join, then we will do his introduction at that time. I hope Premlata has given you all the slides. Yeah. So, and please, DNB students, I can see Sana Siddiqui from Kashyap Memorial. I can see Sameer Ahar from Kashyap Memorial. I can see Shankar. I can see Sanwali. And उसके अलावा कोई नहीं है. सोफिया के PGs नहीं है. सब वीडियो ऑन करो। शंकर, सनवली, सना, समीर,
अंकल को फोन करो, सबको
बोलो ऑन करने
के थक गए।
गेस्ट इतना पढ़ा रहा है, बहुत बढ़िया बढ़िया है, आज स्क्रिपिंग वगैरह सब है, ये है। एंड इतने अच्छे अच्छे फैकल्टी हैं हमारे पास। सो वी हैव फैकल्टीज लाइक विवेक केडिया, डॉक्टर रवि दौलत बरभैया, डॉक्टर भारती शर्मा, शी इज हेडिंग PMH, Dr. Pooja from RP Center AIMS, Dr. Jayanti Kashyap from Maulana Azad, Dr. Nidhi Gatkar, who is the maximum cornea transplant doing surgeon of Jharkhand. इतने लोग हैं और ये पीजी लोग को अपना वीडियो ऑन करने के लिए बोलना है। और ये केवल CCL और कश्यप के पीजी दिख रहे हैं, जो भी दिख रहे हैं सबको ऑन करवाओ। एंड डॉक्टर मित्रा, प्लीज इंट्रोड्यूस द Jhos speakers who have taken lot of in preparing their slides and have come all prepared to impart knowledge.
Yeah, good morning all. I welcome you all to this today's PG training program. There are the important Jhos speakers who are now renowned speakers in our Jhos faculties. Now, I should introduce each one of them. Dr. Nidhi Kashyap. She is in MS ophthalmology gold medalist. She is the DNB FRCS ED from UK, FRCS Glasgow from UK, ICO FICO Cornea, fellowship in cornea she has done, and currently she is working as consultant cornea and cataract services, Kashyap Memorial Eye Hospital, Ranchi. Dr. Jayanti Kashyap. She will be talking on the corneal pachymetry. She is MBBS gold medalist and MSD, currently practicing as general ophthalmologist at Railway Hospital, Dhanbad. Dr. Pooja Kumari, she will be speaking on two topics, one specular microscopy and another is dry eye testing. She is MBBS from Jitmar, Pondicherry, gold medalist, MS Jitmar, Pondicherry, and also gold medalist. Senior residency from RP Center for Ophthalmic Sciences, AIMS Delhi in cornea, cataract, refractive surgery, and ocular oncology. She received the Best Senior Resident Award in year 2019-20 AIMS Delhi. Currently working as a consultant, cornea and cataract services, Kashyap Memorial Eye Hospital, Ranchi. Dr. Vivek Kedia.
Mitra sir, Pooja has replaced Dr. Poonam because she had some urgent meeting and she had to go outside. Okay.
Dr. Vivek Kedia, he will be speaking on keratometry. He is a very good speaker of one of the good speaker of Jharkhand and also from Jamshedpur. Director of Kedia Eye and Maternity Center, Jamshedpur, MS Fellowship in Phaco-refractive Surgeries. Subsequently worked at Shushruth Eye Foundation, Kolkata and Purnima Natrala, Jamshedpur. He is ex-joint secretary of Jhos and currently secretary of Jamshedpur Ophthalmical Society. Very, very dynamic person. Dr. Ravi Daulat Barbhaiya, he will be speaking on scraping. He is a cornea consultant in Jamshedpur, did fellowship in cornea from Shankar Nethralaya, Chennai, ex-consultant Shankar Nethralaya, Chennai, presently practicing in Jamshedpur, and area of interest is lamellar keratoplasty and hepatic keratitis and corneal infection. Then our own Dr. Bharti Sharma, she will be speaking on corneal topography. She is the senior consultant and head of the department of Tata Main Hospital, Jamshedpur. She is a cornea fellow from Shankar Nethralaya, Chennai, and has special interest in cornea, cataract, and refractive surgery. Now, over to Dr. Nidhi Kashyap for her presentation. She will be speaking on foreign body removal.
Dr. Samir, I believe you are in proximity to somebody. There is an echo coming. Can you just switch the positions so that there is no echo loop?
Yeah, who are not speaking, please switch off and mute their Please mute themselves.
Good morning, everyone. Sir, am I audible? Are my slides visible?
Yeah, very much.
Good morning.
Good morning, everyone. Good morning to all my seniors. Thank you, Jhos, for organizing this for all the PGs, and we look forward to a very good session. To all the PGs, we are going to cover some topics which are important more practically to you, and a lot of tips you will get through all these presentations. So I'm going to talk about foreign body removal. Now, foreign body is something which every one of us encounters in the OPD, irrespective of our subspecialties, and the primary treatment can be done by all of us in spite of what we are practicing. So let's go forward. Now, the presentation, removal, and sequelae of a corneal foreign body can be simple to complex. Timely and aseptic removal is important to prevent infection, inflammation, scarring, and vision loss. The modes of injury occur majorly at work, involving high-risk activities and due to lack of or ill-fitting protective gear, and they might be accidental due to projectile foreign bodies. The presentation can be acute or chronic. In cases of acute injury, a patient will present with redness, pain, discharge, diminution of vision, and foreign body sensation. While in chronic cases, there might be redness and pain, but the foreign body sensation may be reduced over time due to epithelialization over the foreign body. There might be just a localized redness and gradual diminution of vision due to other complications. Long-standing foreign bodies invite vascularization and infiltration, which will resolve after the foreign body is removed. These can have epithelialization over the foreign body. These foreign bodies can eventually migrate deeper or superficially. History and examination is very important. We need to know what is the mechanism of injury to find out what is the cause, what is the material of the foreign body, what is the duration, if any previous treatment has been taken. Always avert the lids if some patient complains of foreign body sensation. We need to see the material. Is it inert, metallic, or vegetative? Are the foreign bodies single or multiple? What is the depth of the foreign body? How is the surrounding tissue? Is it healthy? Is there any infiltration or vascularization? Also, watch out for associated anterior chamber inflammation or infection. Look at the lens status and always rule out endophthalmitis. After the removal of a foreign body, we need to manage the epithelial defect in case of superficial foreign bodies, need to give an antibiotic prophylaxis, treat the infection or anterior chamber inflammation. Now, in cases of vegetative foreign bodies, it is important if we avoid patching and giving steroids. In cases of superficial foreign bodies, the removal can be by a simple irrigation or using a moist tip cotton applicator, a 26 gauge needle, jeweler's forceps. Diamond burr polishing can be done, or a magnetic spud can be used. Now, this is the most common type of foreign body that all of us encounter in our OPDs, that is an iron foreign body. So, how to remove it? After anesthetizing the cornea, we need to insert a 26 gauge needle at the tangential angle to prevent perforation, gently loosen the sides, and then dislodge the foreign body. Sometimes these foreign bodies might have rust rings, and these rust rings need to be removed as they slow down healing and cause localized stromal necrosis. And serial removal of rust rings can also be done as they keep on migrating superficially. Complications of such kind of foreign bodies, long-standing, can develop stromal necrosis or secondary iritis due to incomplete removal. They can also lead to an infectious keratitis, either with the foreign body in situ or after the removal when aseptic precautions are not taken. So this is one case. I had a total corneal abscess, and we did not know the etiology, but on looking at the other eye, we found a foreign body. So basically, a foreign body was removed from his right eye, which later developed infection. So the cause should be known in cases of infected keratitis also. Excessive picking or digging of the foreign body might even lead to thinning and a tissue defect or microperforation, which later on needs to be either patched with a tenon patch graft if it is large, or maybe a cyanoacrylate glue and BCL should be done here. Thankfully, this patient healed well and the opacity was paracentral, so did not affect the vision much. So another important thing is a retained foreign body where it is missed. So such cases initially had a very large abscess, and after giving adequate topical antifungals and antibiotics, when the exudates started resolving, we found that the foreign body was retained here. Similarly, this case looks like a corneal infiltrate. When I tried to scrape the infiltrate for culture, I found that below that there was a husk which had penetrated deep, caused a tissue defect and infiltrate overlying it. Similarly, in this case, there is a linear corneal tear, but no foreign body could be seen. He was being treated for over a month. Patient had a streak hypopyon, not responding to topical treatment. And then we suspected there might be a foreign body here in the angle. Took the patient to OT for exploration. And here I removed it using visco. In such cases, if the patient is young, phakic, it is always good to inject pilocarpine first to avoid injury to the lens. So the entry wound here also was unhealthy. So I freshened it, did some intrastromal irrigation and put sutures here and eventually closed the case. And after which he responded pretty well. Again, this is a very common presentation having multiple foreign bodies. This is an old case where the gunpowder has oxidized. Now, removing this gunpowder becomes very difficult because it is very powdery and friable. So if it is in the deeper layers, it might be left in situ. This picture again is very common, firecracker injury, blast injuries, where we have multiple foreign bodies over the cornea as well over the conjunctiva. Now we need to localize at what level are the foreign bodies. If the foreign body is at the level of epithelium or Bowman's membrane, then they can be superficially removed or epithelial debridement can be done. However, if they are anterior stromal, we can wait for a few days for them to migrate up and then a removal can be done. While if there are mid-stromal or deeper, it's better to leave them as it is because they are inert and picking them too much will rather cause more scarring. In cases of deep foreign body, again, location in the cornea needs to be done well. An anterior segment OCT can be done. Look for any endophthalmitis, do the ultrasound and do a CT scan in cases of multiple or deep foreign bodies to look for any intraocular foreign body particle as well. So this is how you will localize. Now, removal of these cases should always be done in the OT. This was a small foreign body removed in the OPD, and then there was a microperforation. So if you are doing it in the OPD, it is always best to review it with a Siedel's test and see that there is no perforation. And doing it on the slit lamp, again, there is chance of lens injury, so that also needs to be taken care of. So in deep foreign bodies, standby always to be required is a bandage contact lens, cyanoacrylate glue, fibrin glue. You might require a suture or you need to do an intrastromal irrigation by antibiotics. Culture might be required, and in very chronic cases or large foreign bodies, maybe amniotic membrane or a Tenon's patch graft might be required. A pedicle conjunctival graft or a tissue patch graft may also be required. Patient always needs to be counseled and taken consent for a risk of corneal perforation in cases of foreign body removal, requirement of a secondary procedure, incidence of scarring, decreased visual acuity, development of traumatic cataract, infection, and endophthalmitis. So a few examples here. This is a case, looked like an infiltrate, but on slit lamp evaluation, there was a foreign body which was protruding very much into the anterior chamber, confirmed by ASOCT, and then removed. Another case looked like a foreign body, but we could not localize it very well. On very high magnification, there was a foreign body inside, and when the foreign body was removed, the patient healed pretty well. This was also confirmed by OC. Now, this is another case of a long thorn injury. Someone tried to remove it and broke the thorn. So rest of the thorn was there and protruding into the anterior chamber. Now we knew that this should be removed in the OT because on removal of this, there will be a perforation. So it was followed up by glue BCL and it healed pretty well. In cases of vegetative foreign bodies, if they are long-standing, the foreign body becomes quite soggy and it is very difficult to remove it in toto. So the foreign body will come out in piecemeal. You have to take care that all particles are removed. Adequate irrigation should be done. And here I'm giving intrastromal antibiotic as well for the residual infection to be taken care of. Seal the entry wound. Some inflammation and exudates were there in the anterior chamber, which were removed. This is another case where foreign body was removed, but still some residual foreign body particles were there. So here epithelium had healed. We had to freshen the epithelium again, reopen the wound. Thankfully, it was not through and through. So anterior chamber was not entered. Again, irrigation was done. And then a BCL was placed and the patient healed well after that. Another case of a chronic foreign body, epithelium has completely healed and no way that it could be removed from the epithelial side. Thus, under viscoelastic, it was removed from the anterior chamber and Seedles was negative here. This case, attempted foreign body removal in the OPD. Foreign body has dislodged inside into the anterior chamber. Thankfully, there was a quite good contrast to remove it. Else, in such hyphema, vegetative foreign bodies can also get lost. Horn injury is very common. Presence like an infiltrate, you don't know there is something inside, but if you keep on treating it, you will find that there is a foreign body which has led to this infection. Similarly, for bee sting injury, this patient presented with an infiltrate, and this kind of corneal decompensation is very classical of a bee sting because it's very toxic to the endothelium, and thus adequate treatment of the infiltrate, the bee sting was found, confirmed by OCT, removed. Another very common foreign body in this belt is caterpillar hair. There can be single or multiple. Now, these are extremely fine and very sharp. So they penetrate into the eye very easily. They might be superficial, can go deep into the anterior chamber, lens, or even the vitreous. And they cause a very severe granulomatous inflammation, rise in IOP. So here steroids is indicated, and obviously removal of the superficial ones is important. So these are few which were tried to be picked and they broke, and then we had to take the patient into the OT and remove them. Deeper hair in such cases can be left as it is, as excessive picking of them will lead to more scarring and significant visual impairment. Just a word on conjunctival foreign body, that is also important. Caterpillar hair can also be found in the conjunctiva, and then patient presents with multiple abrasions. So it is very important to always avert the lid and see if there is a foreign body there. This case was being treated for almost 4 months with having a conjunctival granuloma, which was not improving with any kind of treatment. And then we took her into the OT and explored and found a long thorn inside. And after removal of it, the patient healed well. When do we not intervene? If the stromal foreign body is quite posterior and it is inert, or if it is anterior or mid-stromal and excessive picking of it might lead to more scarring. So the take-home points here will be timely removal of the foreign body, complete removal of the foreign body, always avert the lids, treat any concurrent infection, keep your backup armamentarium, and use of protective glasses cannot be overemphasized. Thank you so much.
Thank you, Dr. Nidhi. Beautiful presentation and the beautiful pictures and the videos also. Now the topic is open for discussion.
I have two just inputs to give regarding this. Excellent presentation, Nidhi. Thanks a lot for that. When it comes to caterpillar hairs, it sometimes so happens that even after averting the lids, we might not be able to see that where exactly is that hair located. So in such cases, when you know that the patient is having some abrasion, foreign body sensation, it's always helpful that we should stain the eye, stain the cornea, So you get a pattern of abrasion on the cornea. That pattern indirectly helps you in finding the location of that caterpillar hair, because sometimes they get buried deep and you are not able to see them in one go. You actually have to go at high magnification and then scan the whole tarsal area to find where the caterpillar hair is. So the staining always helps in narrowing down that area, and we can find the hair in that one particular location and then pull it out. While removing the caterpillar hair, for all the postgraduates who are here, always remember that it has to be pulled out tangentially along the axis of the hair. Make sure that you are not pulling it in such a way that the force is exerted in any other direction other than the axis of the hair. So at whatever way the hair is embedded, you have to pull it out along the axis of the hair to make sure that it doesn't break. And another thing about conjunctival foreign bodies is sometimes the foreign body can go into the superior fornix, and you will not be able to see those foreign bodies even by everting the lids. So in such cases, again, the staining helps. You will get a pattern abrasion on the superior cornea. You're not able to see the foreign body on the tarsal plate. So you should use lid retractors in such cases, and then try to visualize the superior fornix. Even if that doesn't help, flush the superior fornix with saline, because sometimes it just pops out the foreign body that is there. And even if that doesn't help, then you have to go to a little painful procedure. Use a Johnson earbud, put some ointment over it, and then just swipe the superior fornix. And like yesterday, there was a small kid, 2-year-old, who had this fly ash or something which went in the eye. So we could not locate the foreign body. Then the swiping helped, and the stone particles and all came out from the superior fornix. So these are just some inputs. I hope it helps the PGs who are here when they see such patients.
Also, sir, in cases of caterpillar hair, after anesthetizing, sometimes you have to use a bud and swipe it. So while you put pressure, then its point, it comes out, because otherwise, due to chronic inflammation, the conjunctiva and everything becomes quite velvety and thickened. So there might be more foreign bodies which are not seen at the first go. So it's always better to call the patient again. And what I do is I ask the patient to stay back for some time. Let the anesthesia go off, and then again ask him, is it hurting enough now as it was hurting before? So many times they say, no, I'm feeling better. Many times they say, no, now it's hurting on the other side. You can go back again, re-explore, press the conjunctiva a little, and then remove it. Sometimes it is also done on follow-up. So it might not be necessary that everything goes off in one go also. So that needs to be kept in check. You need to call the patient again on follow-up.
Yeah, that's very correct. And we have our guest faculty, Dr. Madhu Uddaraju. We will do the formal welcome before an introduction, before his talk. But he has joined. I had requested him to join so that he can join the local speakers and give his valuable comments also. So your comment on foreign body removal, Dr. Uddaraju?
Thank you, ma'am. Thank you for having me here. I think it was a wonderful presentation by Nidhi, beautiful pictures and excellent videos. I think I have just one thing to add to the discussion regarding the bee sting injuries. I think we had a series of cases when I was there at Aravind Madurai. Almost we had 24, 25 cases of bee sting injuries. I think one important thing in bee sting injuries is the toxin causes more harm than the foreign body itself. So it penetrates into the anterior chamber, and sequentially the patients develop anterior subcapsular cataract and glaucoma. So in these cases, along with and topical steroids, we also started systemic steroids. So when we compare the cases that had only topical steroids with the cases that had systemic steroids, none of the cases with systemic steroids required any intervention. Otherwise, all these cases eventually went into endothelial decompensation, like already mentioned by Nidhi. So one take-home message is whenever you suspect a bee sting injury, make sure that you also start on topical steroids to avoid the detriments of this endotoxin that can go into the anterior chamber and create a problem. Excellent presentation, Nidhi. Congratulations.
So one point from my side, Nidhi, I think when you remove these vegetative foreign bodies, do you give wash with the voriconazole?
I use amphotericin B many a times. I first try to just irrigate it with BSS, and then at the end, the last one, I do give it.
Yeah, because the ones you are showing deeply embedded with hypopion, so it would be a good idea to give an intracameral wash also.
Yeah. If there is anterior chamber involvement, then definitely I do. And if it is mid-stromal, then intrastromal irrigation with antifungal is done.
Yes, okay.
Dr. Madhu, which antifungal you prefer for washing?
I would prefer, voriconazole is better, madam, because it is more against aspergillus that we see commonly, whereas amphotericin B works well for candida.
Okay.
And it is voriconazole also, when compared to ampho, it is less toxic to the ocular structures.
Okay.
But when you have a clear-cut diagnosis of candida, then ampho B is the drug of choice. Otherwise, it would be voriconazole that is especially available as preservative-free form for intraocular use.
Okay, very nice.
So to move ahead, I think we have enough discussion and beautiful discussions. The other speakers are also waiting, so I'll be requesting Dr. Janti Kashyap to share her screen. She'll be talking on corneal pachymetry.
Thank you, sir. A very warm good morning to all of you. And I would like to, at the outset, I would like to thank Bharti ma'am and Jhos for giving me this opportunity. And okay, so my topic for today's presentation is corneal pachymetry. And since this is a PG teaching program, this corneal pachymetry comes both in theory and also in viva voce, and in any case presentation, it has importance. So it is a very important topic for the PGs. So as for multiple topics, if we try to memorize them in headings, it is important. So I will go through the following subheadings: the introduction, indications, uses, types, principles, brief intro of all the techniques, including the advantages and disadvantages, and then the conclusion. So to start with, pachymetry is a Greek word which means pacos meaning thick and metry means to measure. So normally it is used to measure the thickness, but in ophthalmology, it specifically refers to the measurement of corneal thickness. So the normal corneal thickness, as we all know, the cornea is thinner at the center and it's thicker at the periphery. And also in periphery, the thickness is asymmetric, with temporal cornea being the thinnest. And a central corneal thickness of more than 0.65 millimeter is indicative of corneal endothelial cell dysfunction. So coming to the indications, earlier the corneal thickness evaluation was synonymous with glaucoma for the applying correction factor. But nowadays, with the advent of multiple refractive surgeries and various other disorders, the corneal thickness evaluation has multiple roles. So number one is the glaucoma. As we all know, the Goldman applanation tonometry is still considered to be the gold standard. But it tends to overestimate in thicker cornea and underestimate in thinner cornea. So we have to apply a correction factor, and for which we need a very accurate central corneal thickness measurement. Only then we would be apply the correction factor. Then also in congenital glaucoma, it's important for the PGs to know that the normal corneal thickness in day one in infants and newborns, it's slightly higher because of the in utero hydration, because the eyelids was closed, and normally after day one it decreases. So it's important, the corneal thickness evaluation is important to assess in congenital glaucoma to see whether the corneal edema is increasing or not. Also, with the advent of refractive surgeries, the central corneal thickness is very important in pre-operative screening to screen out which patients are good candidates for refractive surgeries or not, and also to plan out which refractive surgery to go, like LASIK, PRK, which one to go out. These the thickness is also very important in post-operative follow-up of keratoplasty patients to know the amount of corneal edema, early graft failure. Also in contact lens, as we all know, the contact lens causes corneal edema. So to know the exact value of the central corneal thickness, it's ideally we should tell the patient to stop using contact lens for 15 days, and then we can have an ideal measure of the corneal thickness. And it is also useful in various corneal disorders like pellucid marginal degeneration, Terrien's marginal degeneration. So coming to the types, the various types are based on the type of energy we used, either ultrasonic or optical, and there are various alternative measures which are used. So the ultrasonic, there are two basic and the conventional ultrasonic pachymetry and the UBM. In optical, we have the manual optical pachymetry, which is not used nowadays. Then the specular microscopy, anterior segment OCT, confocal microscopy. Then we have the scanning slit technology, and which is called the orb scan. And then the newer modalities like pentacam, pachycam, and ocular response cell. I'll discuss briefly these. So, and the techniques are also divided based on the spot measurement and wide area mapping. In spot measurement, a particular spot of the cornea is measured, and in which ultrasound, specular microscopy, confocal, these come under these. And in wide area mapping, as the name suggests, a wider area of the cornea is used, and then the images are interpreted, in which we have the scanning slit method, which is in which we use the orb scan, and then the slim imaging for pentacam, and the anterior segment OCT. So coming to the ultrasonic pachymetry, it is the most commonly which is used, and it is still considered the gold standard. And it was started in the late 1980s by Henderson and Kramer. So coming to the components, it consists of three basic components: the probe, which has piezoelectric crystals of 20 megahertz, and then the transducer, which sends electronic waves and receive the echoes, and the tip. So the important thing to remember about the tip is that it should not be more than 2 millimeter, because it will spread over the lesser area, and the tip of the probe can be seen. If it's the thicker probe, we cannot see the tip of the probe, because the perpendicular placement is very essential for an accurate reading. So this is based on the refraction of ultrasonic waves from the anterior and posterior corneal surface, and the time difference in which we receive back the echoes, that is used to measure the corneal thickness. And this is the formula for transit time into propagation velocity by 2. The important thing to remember that the speed of the sound as air it's only 330 meter per second, but in cornea it is 1640 meter per second. So it is important for the PGs to remember that the perpendicular placement of the tip is very essential for the accurate reading, and because lateral displacement of the probe may cause into peripheral cornea, and it can cause elevated reading. So as it has also both the pros and cons, advantages includes that it is fast, reliable, portable, and it can also be used intraoperatively. Disadvantage include being a contact method. If it is done by beginners and it's not perpendicular, it can cause inaccurate readings, and it can cause wrong correction factors. And since it's a spot measurement, we cannot have a generalized idea of the corneal pachymetry, and it's prone to errors. So coming to UBM, it is a higher resolution. It images the anterior segment. It has a 12.5 to 50 megahertz probe, and since the frequency is higher, the depth is less, and we can have a high resolution images, and it images the anterior segment. So advantages are that the anterior segment, high resolution anterior segment examination can be done, and it is also useful where the cornea is opaque and various layers can be identified. But the biggest disadvantage is that it is a contact method, and we have to immerse the eye in a coupling fluid, as seen in the picture. Patient has to lie supine, and it cannot be used intraoperatively. So coming to manual optical pachymetry, this is just for historical importance, but some of the examiners can ask in viva voce. So it came with an pachymeter attachment to the Hag street lamp, and it consisted of 2 glass plates, as you can see in the picture, and which used to split the images. And it had 2 methods, the just touch method and the overlap method, which we use just like Goldman slit applanation images. But it has a lot of disadvantages, including lack of accuracy, lack of repeatability, and the observer bias. So it is not used nowadays. So these are the 3 new modalities, the orb scan, the pentascam, and the anterior segment OCT. Coming to orb scan, but these topics will be discussed by more our guest speakers. So I'll just briefly touch this. The orb scanning slit technology. It uses a slit method and it gives 4 images, and in which the anterior float, the posterior float, the keratometry, and the pachymetry reading. Just the few important points while coming to seeing the pachymetry point is that the thinnest point should be less than 470 microns to call it abnormal, and it should be outside the 5 millimeter zone. As sir will tell that there are various zones starting from 3 millimeter, 5 millimeter, 7 millimeter, and 12 millimeter zone. And the difference between any one pachy in the 7 millimeter zone and the thinnest pachy should be more than 100 for suspecting keratoconus and different ectasia. And the thinnest point should be more than 30 microns thinner than the central reading. So it has also the basic advantage is that it is a wide field pachymetry and identifies the thinning point, and the precise alignment, unlike the ultrasound pachymeter, is not required. But disadvantage include that it tends to underestimate the thickness in all treated eyes, and the measurements adjusted for are for normal prolate shape, and any change of shape like it interferes with the reading, and it is inaccurate with non-virgin corneas, like in corneas in which it has been operated. So coming to pentacam, it uses the rotating Schlemfer camera, and it can perform 5 functions, which includes the Schlemfer image of the anterior segment, the anterior chamber analyzer, pachymetry, corneal topography, and cataract analyzer. So we can have multiple functions, and it is good that it is non-invasive, non-eye contact, and even minute eye movements are captured and corrected simultaneously. But it underestimates the corneal thickness in comparison to ultrasonic pachymetry. So this is the maps, and these topics will be dealt with separate speakers. So coming to pachycam, it is a compact and portable non-contact pachymeter with a built-in keratometer, and it can be mounted on a slit lamp, so it can be easily used. And the advantages include non-compact, and it is compact, portable, and lightweight. So coming to the next, that is the anterior segment OCT. It is a high resolution non-contact OCT customized for the anterior segment, and it gives the color-coded map of the corneal thickness. So advantages also include that it's non-contact, and rapid scans can be measured, high resolution. And in this, after LASIK, we can document the flap thickness and the residual stromal thickness immediately following LASIK surgery, and we can measure through the corneal opacity. But the disadvantages include that it cannot penetrate through the pigmented or scarred tissue, and since these are technologies based, so it has a low rate of refreshment. Specular microscopy, these will also be dealt with our senior colleagues and ma'am. So this is the oldest method to corneal thickness. Important thing to remember for the PGs is that compared to the ultrasonic pachymetry, in which we use the ultrasonic waves, sound waves, in this the distance we use light waves and the focusing of light waves through the anterior and posterior surface of cornea, and then we measure the corneal thickness. These are of 2 types, contact and non-contact. Non-contact is most commonly used nowadays, and it's easily available in medical colleges and all. It is operator independent since it has an auto-generated program, and it's non-invasive, and we can measure the endothelial cell count simultaneously with this. Disadvantages include that the exact point where reading is taken is not known, it's time consuming, and it cannot be used in the OT, and it is not good for reading cannot be taken in scarred corneas or cornea with edema. So confocal microscopy, these are more of research kind, and it used in medical colleges, and we can view the higher magnification of the thickness of each individual layer, not only the whole thickness, but the thickness of each layer of cornea can be measured, and it has good repeatability. But disadvantages include that the reading of the ultrasound pachymeter and these, they do not correlate, and it has a tendency to overestimate, and it depends on the various factors like lens hydration, post lens tear film, and the observation angle, and it has a slower data acquisition compared to the ultrasound pachymetry. These are optical low coherence reflectometry. These are just for knowledge. They are not very much commonly used, and it is an instrument based on the slit lamp, and it measures corneal thickness very precisely, and it is based on the principles of Michelson interferometer, but we should know these names. And laser Doppler interferometry, it is a non-contact technique that uses dual beam infrared laser to measure the corneal thickness, and there is limited data And this, similarly for ocular response analyzer, these are newer modalities for measuring the biochemical mechanical properties of cornea, and it utilizes a rapid air impulse to measure the corneal thickness. So the take-home message is that there are different methodologies which are based either on ultrasound or the optical principles, but still ultrasound pachymetry is considered to be the gold standard, and the values obtained through different techniques may differ. Thank you for your kind attention.
Thank you. Very exhaustive presentation.
Yes.
I request all the PGs to be in the discussion. Ask your questions. So if there is no questions and no inputs, then we should move ahead. I request Dr. Pooja Kumari to start her presentation. She will be speaking on specular microscopy. Dr. Pooja Kumari, please.
Thank you for the introduction, sir. A very good morning to everyone. So I'll be speaking on specular microscopy. Are my slides visible?
Yes, you are visible. Audible also.
So a little bit of background. In 1922, Vogt first described in vivo imaging of the corneal endothelium, and in 1968, Morris was the person who first developed first specular microscopy to study the endothelium in vivo. So specular microscopy is a non-invasive photographic technique that allows visualization and analysis of the corneal endothelium in terms of quality and quantity. As you all know, the endothelium is the innermost layer of the cornea, and it is a monolayer which consists of polygonal hexagonal cells, which are simple squamous type in nature, and it's arranged in a mosaic pattern. So first of all, we should know what is specular reflection. So the specular term, it has originated from Latin word, which is specularis, and it means mirror-like. So specular reflection is the reflected image of the light source itself. And it follows Snell's law of optics, which says angle of reflection is equal to angle of incidence, which we have read in physics. And the brightness of the reflection depends on the reflectivity of the surface on which it is seen. So once we are doing specular reflection on slit lamp, we have to remember that the observer arm and the illumination arm have to make an angle of 60 degrees, and the beam should be parallel pivot beam. And your magnification should be high, and intensity should be maximum. Then only you'll be able to visualize the corneal endothelium on slit lamp. So this is an image which is showing the abnormal endothelium. It's a case of Fuchs endothelial corneal dystrophy, and other structures like pigments, heterogeneous cells, beaten metal appearance, all these can be visualized when you are seeing with specular reflection. Now coming to principle of specular microscope. So what happens is the light which is incident on the epithelial surface, it transmitted and passes through the corneal tissue, but most of the light, what happens, it gets absorbed by the corneal tissue, and some gets reflected by the nerve fibers and keratocytes. Few amount of light is transmitted through the corneal tissue, and among that, the light which is incident on the posterior corneal surface, most of them get transmitted into the aqueous. Among this light, only 0.022% is reflected due to the change in the refractive index at endothelium aqueous interface, and this reflected light is captured by specular microscope and endothelial image is processed. So there are various types of specular microscope. We have contact and non-contact, but these days we are using the non-contact ones. Among these, we have Topcon, CEM, Tomies, and Conan specular microscope. So the Conan one we use in eye banks that I'll be discussing later on. Now coming to normal morphology of an corneal endothelium, it's a monolayer polygonal hexagonal cells which is arranged in a mosaic pattern. An average size of an endothelial cell is around 20 microns, and surface area is around 100 to 250 microns square. Thickness is around 5 to 6 micron, and it gets developed in 4th week of intrauterine life itself. The progenitor cells for corneal endothelium is neural cell with participation of mesenchymal mesoderms. So there are 3 transcription factors which you have to remember, that is FOX, C1, PITX2, and PAC6. Mutation in these genes only can lead to corneal endothelial dystrophies. So in this image, you can see this is a normal endothelial, which is nice hexagonal cells and arranged in a mosaic pattern. And you can see the borders of these cells are dark in color and the cell cytoplasm is light in color. This holds a very good importance because later on I'll be discussing about various corneal pathologies in which these changes will occur. Now, before doing a spectral microscopy, you have to explain the procedure to the patient properly, and the blink should be adequate. If the surface is irregular, then you should instill lubricating eye drops, and then you do the procedure. In contact procedures, you can always instill local anesthetic agents, and you have to instruct about the fixation target which you instruct the patient. So type of image capture will be automated, semi-automated, and it could be manual. So these are the images which you see. So first of all, what happens, patient details and eye will be displayed on the microscopy. The second, the corneal endothelial image will come. And then here you can see in this chart, this number has been shown. So this number basically gives the number of endothelial cells which has been captured, which will calculate the cell density per millimeter square. And it also gives the average size of the cells along with standard deviation, along with coefficient of variation, which is denoted in percentage, the maximum size of the cell and minimum size of the cell. I'll be discussing about each parameter later on, one by one. It also gives the central corneal thickness of both the eyes. Along with, it gives the area, which will denote the polymegathism and pleomorphism. So for polymegathism, it has given the range of the cell size, and in that range, how many cells are being analyzed, it gives all the data. Along with hexagonality, how many sided cells are there, it has given the values. So I'll be discussing that. So coming to endothelial cell morphology analysis, cell area plus minus standard deviation, it will be measured by the system. We have to mainly focus on the cell density, polymegathism, and pleomorphism. So first, cell density, it's measured by this formula, which is 10 raised to the power 6 upon average cell area. It gives cells per millimeter square. Polymegathism is coefficient of variation, which is derived with the equation standard cell area upon mean cell area micron meter square. And pleomorphism is the percentage of hexagonality. So first we'll discuss coefficient of variation. What is that? It's basically a measure of polymegathism, that is the variation in the cell area. So measuring areas of population of cells and calculating the coefficient of variance, which is standard deviation of mean cell area divided by the mean cell area. So less than 0.4, that is 40% is normal. If it's more than 0.4 or more than 40%, that is abnormal. So in this image, you can see the CV is around 33% and cell density is 2839 cells per millimeter square and hexagonality is around 51%. So this is the image which is showing the polymegathism. So you can see the variation in the shape of the cell. So some cells are larger in shape and some are smaller in shape. So there is so much of variation present. So this is called as polymegathism. Now coming to hexagonality, it's measure of pleomorphism, that is variation in the cell shape. So here basically most of the cells are hexagonal, that is 6-sided. So in this, we have to see how many cells are less than 6-sided and how many cells are more than 6-sided. So in healthy corneas, around 70 to 80% of cells should be hexagonal. So here you can see it's around 51%. So it's slightly towards the lesser side. In this image, you can see this is a normal endothelium image. So here almost most of the cells are hexagonal and all are almost equal in shape. Here you can see this is polymegathism. Some cells are large, some cells are small. So there is so much of coefficient of variation. So that's why this is a case of polymegathism. Here you can see this is a case of pleomorphism. Some cells are 4-sided, some are 8-sided, some are 6-sided, some are 2-sided. So much of variation is there in the size of the cell. So this is an example of pleomorphism, which is denoted by hexagonality. Now there are various methods for the measurement of specular count. So there is a fixed frame method, center to center method, flex center method, corner method, and comparison method. So we won't be discussing everything. So for exam point of view, these two are important: fixed frame and variable frame. So fixed frame, basically we take a fixed frame, and whatever cells are being included in this frame, those cells are being measured. So it could be half of the cell or 1/4 of the cell or more than 1/3/4 of the cell. So if that endothelium, the nucleus is within the frame, that those cells can be measured. But in variable frame, basically it goes from edge to edge. So edge of the endothelial cell layer, all the cells are being taken. So variable frame is considered to be the more accurate as compared to the fixed frame, because subjective variability can be seen in fixed frame method. Now there are various clinical clinical applications which can be seen with the help of spectral microscopy. As in primary endothelial corneal dystrophy, we can diagnose the cases of fuchs endothelial corneal dystrophy, then posterior polymorphous corneal dystrophy, congenital hereditary endothelial corneal dystrophy, and ICE syndrome, iridocorneal endothelial syndrome. In secondary corneal endothelial disorders like post-surgery also, if the patient is developed a post-pseudophakic bullous keratopathy, and then endothelial cell changes can be seen on specular microscopy. In case of pseudoexfoliation, diabetics patient, post-forceps injury, uveitis. In cases of endothelitis and a contact lens wear also, you can see endothelial changes on spectral microscopy. First, coming to Fuchs endothelial corneal dystrophy, it's characterized by the formation of desmus membrane excrescences, which are also known as guttae, that are focal thickening and projections in the otherwise homogeneous desmus membrane. They could be fine or coarse guttae, or it could be confluent and non-confluent. So it presents from center to periphery. So first it begins in the center, and then later it progresses to peripheral cornea. And one more thing also I want to mention, that the endothelial cell count, it's more in the periphery as compared to center. So this is a procedure which is known as DWEC, which is Descemet's rhexis without endothelial keratoplasty. So if the peripheral endothelial cell count is more than 1000 per millimeter square, so in case of FECD, this procedure can be performed. Now, corneal guttae. So these are basically focal droplet-like accumulations of a non-banded collision on posterior surface of desmus membrane. So these are present in the dark area. So here, whatever dark areas you're able to see, these are all corneal guttae. This is an image which is showing a Fuchs endothelial corneal dystrophy. So here also you can see dark areas, which is suggestive of corneal guttae. So this can be easily captured on specular microscope. Next is the case of posterior polymorphous corneal dystrophy, which is characterized by vesicle bands and placoid lesions on the endothelial surface. So here you can see these band-like lesions and some few vesicles on the retroillumination. And here also you can see that the cell density has also reduced. It's only around 1176. And coefficient of variation also, it's around 77%. So I told you less than 40 is normal. So anything more than 40% is abnormal. So here you can see polymegathism is there. Now next is ICE syndrome. It consists of Chandler syndrome, progressive iris atrophy, and Cogan-Rees. So here these three changes predominantly you'll be seeing, that is the rounding of the cell borders. So as you know, the cells are hexagonal in shape, but sometimes the rounding happens due to changes in the endothelial cells, and there is increased intracellular blackout areas. Here you're able to see these blackout areas, which is seen in ICE syndrome, and dark light reversal pattern. This is very, very important, because previously I showed you the normal image. In that case, the borders are light in color and cytoplasm is brighter in color, but that reversal happens in ICE syndrome. So here you can see the borders are light in color and the cytoplasmic area is dark in color. So this is known as dark light reversal pattern, which is characteristic of ICE syndrome. This is a case of pseudophakic bullous keratopathy. So here also lot of coefficient of variation, you can see it's around 83%. So a lot of polymegathism is going on, and cell density is also increased around 1367, and maximum cell size is also very, very large. And here also you can see 6A is basically the hexagonal shape of the cell. This is only 43%. So normal 70 to 80% is taken. So these are the number of cells which has been denoted on the map. This is one case of CMV endothelitis. Here also polymegathism and pleomorphism you will see, but this characteristic owl's-eye inclusion bodies are seen on the endothelium, which can be captured by specular microscopy. So here, this is a normal endothelium, and here you can see patient with diabetes mellitus. So in diabetes also, the function of endothelium kind of goes down, and here cell density is also reduced, and coefficient of variation is also quite high, and here you can see the hexagonality is also low. So this is a poor endothelium in a patient with diabetes mellitus. Other applications, as I told, in eye banks also, spectral microscopy can be used. So this is an eye bank microscope. So here one socket is there. So you can insert the bottle with a media with a corneal button, and you can put in the socket. It should be warmed to 25 degrees centigrade before evaluation. Otherwise, the reading won't come, and the warming time can be around 45 minutes to over 2 hours. So once it's a very good system because it's a non-invasive, it's a closed system, and there is no chance of any contamination of the viewing chamber. So it basically gives a specular count and imaging of the corneal endothelium. So based on that, you can assess the quality of the corneal endothelium, and you can decide whether you want to use it for therapeutic purpose, or you want to use the tissue for optical keratoplasty. So usually if the count is more than 2000, we consider it for optical keratoplasties. And if the count is really good, like 2300 to 2500, then we can consider that tissue for doing surgeries for endothelial keratoplasties. Spectral microscopy also gives an information about the pre-op health of the cornea, and it also gives information regarding the planning of the surgery. So if the patient is having a very low count, then ideally it should be contraindicated cataract surgery. But if the cataract is quite dense, then use of viscoat and other advanced technologies, we can still perform the surgery. And if the count is around less than 1500, then usually ACILs are kind of contraindicated. And when you're planning for phakic ILs also, the count should be really good. If the count is less, then should be contraindicated. And if the count is really less with cataract, then we can plan for a combined procedure, whether it's a DSEC triple or DMEC triple, that depends on the surgeon's preference. Aging also has an impact on corneal endothelium because the counts are really good by birth, around 5,000 to 6,000 per millimeter square at birth, but it declines by 0.6% per year. So every year you see the decline with age. And based on the reports, we have seen that various surgeries also causes decline in the corneal endothelium count, whether it's phacoemulsification or ECC, SICS, keratoplasty, DSEC, DALC, DMEC. Most of the surgeries, they do have a decline in the corneal endothelium counts. So the advantage of spectral microscopy is that it's simple and valuable tool for the evaluation of corneal endothelium in normal and diseased eyes. And clinico-specular correlation helps in making an accurate diagnosis of a condition, assessing the functional reserve of the cornea, and pre-op evaluation in surgical management. But the disadvantage is that it only visualizes a small part of a cornea at a time, and it ignores the regional variations. As I told, that ECD is higher in peripheral areas, and paracentral cornea, it's kind of less. So it has some regional variations. So that is one disadvantage. So this is an article which was published in IGO last year, Spectral Microscope in Clinical Practice. So you can go back and read this article. It gives a very good information about spectral microscopy. Thank you so much.
So, all right.
Any questions or any inputs? Nice. Presentation. He has made the topic very simple.
And सबसे बड़ी बात क्या है कि she has come in emergency because this topic was for Dr. Poonam Singh. So she agreed to accept the topic. So I appreciate you, Pooja, for that.
Thank you, ma'am.
So Dr. Madhu Raju is actually seeing one emergency patient. So we won't be able to take his input. First, I will check the attendance of PGs. Again, only Sanmali and our PGs and this Sayanti and Kashyap PGs. Yeah, Dr. Richa, and nobody is from Sankar and Kashyap ka PG. Log apna camera on karo. कश्यप का कैमरा ऑन करो। सना, सना
मैम ऑन है।
ऑन है, किधर? दिख ही नहीं रही है।
यस मैम, कॉन्फ्रेंस हॉल।
ठीक है, कॉन्फ्रेंस हॉल में सब बैठे हुए हो ना? ठीक है, ओके ओके। So you found that this is very interesting and very useful topic for you guys. Specular, you do every day. Testing, foreign body, then pachymetry, you people do every day, all the PGs. So अभी PG का और जो PG लोग अपना वीडियो कैमरा ऑन नहीं किया है उसको हेड फैकल्टी से पनिशमेंट मिलेगा, चाहे वो CCL हो और बोकारो हो या कश्यप हो, सब जगह से हेड फैकल्टी से पनिशमेंट मिलेगा। हम लोग संडे छोड़ के अपना आए हैं, इसके मित्र हैं बेचारे, रिलैक्स नहीं कर रहे हैं। तो अब ओके, सो डॉक्टर मित्रा, ओवर टू यू।
Yeah, now move ahead with our Dr. Vivek Kedia. Request Dr. Kedia to share his
अच्छा, एक मिनट मित्रा, ये I had surgeries posted today, so I have given those to Dr. Pooja. So can we finish Dr. Pooja?
Yeah. Dr. Pooja, you can stick on the dry eye testing. She will be sticking on dry eye testing.
Because she has to rush to OT.
Yes. Please, Dr. Pooja, share your screen. Yeah.
Pooja, dry eye.
Are my slides visible?
Yes.
So my next topic is on dry eye testing. So I'll be discussing most of the reports which was given by Jhos 2, that is Dry Eye Workshop 2, which was published in TFOS, that is Tear Film Ocular Society. So first of all, we have to know what is a dry eye disease. So dry eye is a multifactorial disease of the ocular surface, which is characterized by loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play an etiological role. So each and every term is very, very important. It's a multifactorial disease of ocular surface. There is a loss of homeostasis of tear film, which causes ocular symptoms, and it causes tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play an etiological role. This is an algorithm which was published in Jhos 2. So I won't be focusing on risk factors, classification, and management part. My focus will be only on the testing part, which is the diagnostic test. So they have given two types of tests, screening test and homeostatic markers. So in screening test, they have given two questionnaires, which is DQ questionnaire and OSDI questionnaire. So I'll be discussing that. You can choose either of the questionnaire plus one of these homeostatic markers, that is the non-invasive tear breakup time should be less than 10 seconds. Osmolarity of the tear, if it's more than or equal to 308 milliosmol per liter in either eye, or interocular difference of more than 8 milliosmol per liter, and ocular surface staining. Ocular surface staining also I'll be discussing later on. If it has more than 5 corneal spots, or it has more than 9 conjunctival spots, or lid margin staining of more than or equal to 2 millimeter length, and more than or equal to 25% of width, then these conditions is in favor of dry eye disease. So I'll be discussing everything one by one. Now coming to the questionnaire. So this is a DQ5 questionnaire. So 5 questions are being given. So you ask the patient each questions one by one and you give a score. So if the score is equal to more than or equal to 5, then the patient is having dry eye. Next is OSDI, which is Ocular Surface Disease Index. It also has a various set of 12 questions, and based on that, the scores are being given. So if the score is more than or equal to 13, then the patient falls in the category of dry eye disease. This is the Schirmer's test, which is the most commonly test which is performed in routine OPDs. So here we use this Wortmann's filter paper, and it is inserted in the later 1/3 of the canthus, and it's kept for around 5 minutes. And you have to look for the wetting of the strip. So mark has been given in the strip. So the maximum mark is around 35 millimeters. So if the wetting is more than 10 millimeters, that is normal. And if it's less than 10 millimeters, that is universally considered as a dry eye. If it's less than 5 millimeters, that is a severe dry eye. But the Schirmer's test has a very poor reproducibility, and a lot of variations are also seen in this test. So that's why this is not included in Jhos 2 report. Next is the TBUT, that is a tear film breakup time. So tear film breakup time, this is a small video. So from the last blink to the appearance of the first break in the tear film, you have to count. So here you can see this is the break in the tear film. This is the blink, and here this black spot you're able to see horizontally. This is the breakup time. So if it's less than 10 seconds, 10 seconds is the cutoff. So if it's less than 10 seconds, then the patient is having dry eye. So here you can see in this image, the patient has a normal staining, and here you can see a lot of break in the tear film. Now, NEI workshop grading. NEI is National Eye Institute grading. So it has given a grading system for both cornea and conjunctiva. So for cornea, it has given 5 areas, and for conjunctiva, 6 areas have been given. So once you do the staining, you have to count the number of spots in each quadrant. And for cornea, if the number of spots are more than 5, it is considered to be dry eye. And in conjunctiva, if the number of spots counts to be more than 9, then that is considered to be the dry eye. So based on this, various grading also has been given. So you can go back and read this in details. Lid margin is also an part of ocular adnexa. So lid margin, this is the case of lid viper epitheliopathy. So here you can see the staining is more than or equal to 2 mm in length, or more than 25% of the width of the lid margin. This is considered to be the poor ocular surface. Now, this is a very interesting instrument, which is ocular surface analyzer. It can evaluate the quantity and quality of a lipid component of a tear film. So as you all know, the tear film consists of lipid layer, which is the outermost layer, followed by aqueous layer and the mucin layer. So it also measures the tear meniscus height, and tear breakup time is also being measured by this machine. It also images the meibomian glands. Also pupilloplasty and white-to-white measurement can also be seen. So I'll be discussing about the protocols. I won't be discussing everything. Whatever is relevant to you, I'll be focusing on that. So interferometry, tear meniscus, NIBUT, that is non-invasive breakup time, eye blink, and meibography. I'll be mainly focusing on these parameters. It also has OSDI scoring that based on the questionnaire, you can fill in this software and it will give you the scoring. So this is a first test, which is the interferometry. So interferometry basically measures the lipid layer thickness. So lipid layer thickness, so you just see the video. This is a small video. So here you can see some white shining interference area over the cornea. So this is basically due to the lipid layer. We have not installed any dye in the eye. This is just the normal your tear film. So see here in this image, you can see the lipid layer component. This fringe is very, very nice and bright. So here you can see this software has given the lipid layer thickness also. So this is coming the green area. The measurement is around 99. So the ideal thickness should be more than around 60 nanometer. So if it's less than that, that is poor lipid layer thickness. And if it's more than 60, that is a good lipid layer. This is a case of bad lipid layer. So here you can see the reading is around 54 nanometers. So lipid layer thickness is very less. And here you can see the color of the fringe is also very, very dull. So why this fringe occurs is because the lipid layer, the topmost layer of the tear film, it acts like a prism which refracts the light. And the more lipid, it more refracts. And the image quality becomes more sharpened. And here you can see the rainbow-like pattern is also seen because of the good lipid layer thickness. In this area on your left, you can see the shine is very, very dull, and because of the less lipid layer. So that's why the had not occurred. This is a case of lipid layer, good lipid layer. And here also you can see the rainbow-like pattern. This is a case of a bad lipid layer. So I'll just go on to the video. This is a small video. So here you can see. So the capillary action, the lipid is kind of going up, and beautiful, nice colors and sharp image you're able to see. This is a case of poor lipid layer thickness. So here you can see the image is not very bright, and very less amount, very dull colors are seen here. This is how with this machine you can measure the lipid layer thickness. Now the next component is tear meniscus height. So tear meniscus height is also very, very important. So it measures the height in all the area along the lid margin. And if the height is, the ideal height should be around 0.25 millimeters. If it's less than that, then that is a case of aqueous deficient dry eye. So here you can see the thickness is kind of less. It's only 0.16. Here it's 0.17. So this is a lower lipid-led meniscus. Sorry, the tear meniscus. Now the next one is NIBUT. NIBUT is non-invasive breakup time. Non-invasive, why? Because here we are not using the fluorescent dye. Here we are just using the software, and the Placido ring is being projected over the cornea. So the patient is looking into the machine, and whatever the Placido rings are there, that is being reflected very nicely on the cornea. So here you can see these are the Placido rings which are seen on the cornea, and if the patient is having dry eye, the Myers will break very easily. So that can be seen very nicely. That's why it's called as non-invasive breakup time. This is a small video. Here you can see these rings are visible very nicely, and the patient has a good lipid layer component also. And now after some time, the Myers are kind of breaking. So here also the cutoff is around 10 seconds. So if it's the Myers are breaking less than 10 seconds, that is considered to be dry eye. If it's more than 10, then the patient ocular surface is quite good. So this is a case of NIBUT. Here the reading has been captured as 7.28 seconds. So that this is less than 10. So the patient is having dry eyes. Next is mebography. So here it images the meibomian gland, meibomian glands also. This imaging is very, very important because we have to know about the health of the glands. So here you can see the gland loss area also it measures. So in this case, it's around 37% or 39%. So based on this, we can actually prognosticate the case, and we can give adequate management to the patient. So this imaging really helps with the management of dry eye disease. Next, it also gives information about the blink. So the blink quality is very, very important for assessing the dry eyes. If the partial blink is more than 50%, then that is considered to be abnormal. So normally we blink around 12 to 15 times per minute. So if the blink rate is also less, that is also a problem. So that also this machine can calculate and tell you. This is how the result panel is shown of this ocular surface analyzer. So this is just an overview of everything. So it gives information regarding non-invasive breakup time, about the eye blink, lipid layer thickness, about the mebography imaging of both upper and lower eyelids, about tear meniscus height, OSDI scoring also it gives, and last is the osmolarity. So osmolarity I'll discuss. So for tear osmolarity, as that in definition itself, I have told that if the tear is hyperosmolar, that results in the increased inflammation and causes ocular surface damage. So this is a machine by Tear Lab. So here a pen like it's like a tono pen kind of thing, and this cartridge are there. So we have to insert this cartridge in the pen, and from the lateral tear meniscus we have to take around 50 nanoliters of tear, and it gives you the value. So the cutoff for this tear osmolarity is around 308 milliosmol per liter. If it's more than that, then your tears are hyperosmolar, and interocular difference should not be more than 8. So this is a very good tool for dry eye assessment. Now, at last, this is a contact procedure basically. So this is to image the cornea, conjunctiva, and limbus at the cellular level. So this is a confocal microscopy, and it gives an on-fast images of the corneal cells and structures, and it gives high resolution images to navigate through all corneal layers. So it basically gives you the imaging of the cornea, how much damage has occurred at the cellular level. So this is how a normal epithelial cell would look like on a confocal microscopy, and this is a normal basal cells. But in cases of dry eye, you can see the cells are kind of desquamated, and this does not look healthy at all. So this imaging can only be seen in confocal microscopy. Here, these are the normal subepithelial nerve fiber bundles, but in dry eye, what happens, these nerves are kind of attenuated. That's why the sensations are also reduced if the patient is having chronic dry eye, because the nerves are getting damaged. So this can be very well captured on confocal microscopy. In stroma, you can see these are healthy keratocytes, but these keratocytes are also getting damaged, abnormal stroma, and an abnormal endothelium can also be captured on confocal microscopy. Thank you so much.
One more beautiful presentation with the beautiful pictures.
Thank you, sir.
Any questions and any inputs? Postgraduates, please come out with your questions.
Anushri, Dr. Madhu, you would like to say something?
Yeah, I actually missed the initial part of the presentation. Was staining covered, madam? Ocular surface staining, Dr. Pooja?
Yes, sir. I have mentioned about the NEI scoring.
Oh, okay, right. The conjunctival spots and corneal spots.
Yes, sir. Yes,
Yeah,
sir.
I think that is more practical for most of the people in private practice because they may not have access to most of the dry eye thing. So I think 5 corneal spots, 9 conjunctival spots, and lid margin of 25%.
Yes, sir.
Those are all more practically, and using of Lesamine green, especially instead of
Yes.
fluorescein. That is very important. Yeah, very nice presentation.
Thank you, sir.
So over to
In
Dr. Vivek now.
practical,
Please
Yeah.
share your screen. And we are waiting for keratometry.
So we welcome Dr. B. Kashyap. I saw him, he has joined. So welcome, Dr. Kashyap. Please turn on the video. Camera.
Thank you, madam. Thank you.
Thank you, sir, for joining us today.
Yeah, I just came up from the 40. So
is my screen visible, sir?
Dr.
yeah,
Madhu Udaraju is also here, our guest speaker. He is the Chairman Scientific Committee of Andhra. So he is also there and he is also commenting and giving his valuable opinions, pearls of wisdom after each talk. Okay, welcome, Dr. Kedia.
Thank you, ma'am. Thank you to Jharkhand Ophthalmology Society for holding this wonderful session and giving me the opportunity to share a very important topic which all of us come across. Almost everyone has to know keratometry in and out and the uses that it has in our clinical practice. So I'll be basically discussing keratometry under these headings, like introduction, the principle of keratometry, what types of keratometers are being used, what are the parts of the basic instrument, the procedure of keratometry, what is extended keratometry, and the uses and limitations. So keratometer is basically an instrument which is used to measure the central corneal curvature. So kerato means cornea and metry is the measurement. And keratometry is the optical technique which is used to measure the anterior curvature of central cornea. The central 3 to 4 mm of cornea is being measured by keratometry and it is expressed in dioptric power or dioptric curvature. So basically what happens in keratometry is that when we have an object which is creating an image on the cornea, so the reflection of the image, the size of the image will depend on what is the curvature of the cornea. Now, the cornea acts like a convex mirror. When any object light falls onto the cornea and the reflection which is based on the Purkinje images is the size of the image is depending on the shape and the curvature of the cornea. So we have read in our basics that when light falls on the cornea, there are 4 reflections from the cornea and the lens surface. The first and second Purkinje images are from the anterior and posterior surface of the cornea. The third and fourth from the anterior and posterior surface of the lens. So keratometry is based on the image which is reflected of the first Purkinje image, that is from the convex surface of the anterior cornea. So the principle of keratometry is that it's a relationship between the size of the object and the size of the image that is reflected from the surface. The radius of curvature is determined by the apparent size of the image of the bright object. So here the bright objects are the Myers, which are projected onto the anterior surface of the cornea. So the reflection of these Myers is the image from the anterior corneal surface, which is then detected by the observer, and the size of the image is compared to the size of the object through a formula which takes into consideration the refractive index of the cornea, and thus the keratometry values are determined. Here, for PGs, one thing is important to note that when we talk of keratometric refractive index of cornea, it is 1.3375. But when we talk of just the refractive index of cornea, then that is different. That is 1.376. But when we talk of keratometric refractive index, that's 1.3375. This is important even for your exams and Viva OC. So this image, this diagram tells us that if we have an object, it causes a formation of an image. So this is the image size, the image shape, which is again erect, but the size will be different compared to the object. And this image size is then received by the observer, and then the radius of curvature is calculated. So since the eye is constantly moving, there are always micro movements in the eye when we are measuring the curvature. It is extremely impossible to get the exact size of the image. So to solve this problem, Ramsden developed a technique called the doubling technique, wherein two prisms were incorporated in the travel line in the path of the light of the image, which is being reflected from the cornea. And these prisms separate the image light, and thus they help in creating two different or doubled images, which does help us in finding out the curvature. So the idea of these principles of these prisms is that when light comes from the image, when it reflects back, it is split through four different holes, with one hole making it pass through a vertically oriented prism, another one making it pass through the horizontally oriented prism, and two different holes let the beam of light go through straight ahead to focus on the central mire. How they look is will be shown later on. So based on that, what kind of doubling system are we using means that whether the object is being doubled or the image size is being doubled. Based on that, there are different types of keratometers. So when you have an fixed object height and a fixed doubling device distance, means the distance of these prisms is fixed, then you get something called as fixed doubling. So the most common keratometers that we use, like Bosch and Lomb or the Topcon auto keratometer, they have this fixed doubling method wherein the object size and the doubling device distance are fixed. But the image size and the Meyer separation, that can be varied in these keratometers. Whereas in variable doubling keratometers, the object height and doubling device distance, they are variable, but the image size and the Meyer separation are fixed. For example, in Javel-Schwartz keratometer or Haas-Fried keratometers. Again, keratometers can be divided into one position and two position keratometers. One position are those wherein the principal meridians are oriented at 90 degree to one another. So when we measure one particular axis, we assume that the other axis is at exactly perpendicular 90 degree to the first axis. These are called one position keratometers. Two position keratometers, they require movement or rotation of the whole system so that you can get the other axis for keratometry. Two position keratometers are actually very helpful when it comes to measuring cornea with irregular astigmatism, which is very difficult to be done with one position keratometer. So this is the most common keratometer that we use. This is the Bosch and Lomb keratometer. This is an anterior view from the side of the patient. This is from the side of the examiner. So it has some parts. This is the chin rest. This is occluder. Now this is the horizontal drum. The horizontal drum helps us to focus the plus Meyers. There is the vertical drum on the opposite side, which helps us to focus the minus Meyers. This is the axis measurement, and this is the dial which is used to rotate the keratometer along its length to finalize the axis of measurement. So you have this knob which helps us in lifting the keratometer up and down to position it along the patient's eye. This is a very important knob. It helps us in adjusting the chin height, and this one is used for focusing of the Meyer. So this knob is the first one that we use when we actually have to focus the Meyer, the image of the Meyer on the center of the cornea of the patient. So yeah, this slide shows the same thing, all the parts. So when we come to the interior of the Boschelbaum keratometer, so it has an illuminating system which will illuminate the Myers which are made on this mirror. So the light then travels through the condenser into the patient's eye, and from there the image again reflects back. It is passed through the doubling prisms, and then it reaches the observer's eye through the eyepiece, and thus it helps us in focusing the Myers. So this is the Meyer image that is focused on the surface of the cornea, and this is the objective, and the light reflected from this objective goes onto the surface of the cornea, and this is how we see the image through the eyepiece. Now, mostly we'll see that the image initially is in this position. So in this position, what we need to do is that first of all, you have to rotate the axis. This is telling us that the axis are not at 90 and 180 degrees. That is something else. It is twisted. So you have to turn the rotating drum and make sure that the plus signs are horizontal, aligned with each other, and the minus signs are vertical to each other in straight axis. Then once we achieve that position, now you'll see that the central Meyer will be defocused. You'll see two double images. This is happening because of the light that is being passed through the prisms, as well as the light which is going across directly onto the observer's eye. So you use the focusing knob and you make sure that the central image is first oriented properly, and both the Meyers are overlapping, and you see one single Meyer. The plus sign in center has to be aligned to the center of the circle, because this tells us that the keratometer is fixed right in the center of the patient's cornea, and it's aligned with the pupil. Next, we come to the use of the horizontal drum, which is on the left side. So this horizontal drum has to be moved till the plus signs, which are separate over here. These plus signs should come and overlap each other, and it should become one single plus sign. So that is being done by the horizontal drum. It will give us the horizontal K value. And then we work on the vertical drum to focus on the separated minus signs. These minus signs have to be brought together into one single focus, and this will give us the vertical reading. So both of these now will give us what is the curvature of the end dioptric power of the horizontal axis as well as the vertical axis. We can now, these Boschelbaum keratometer generally has a range from 36 diopter to 50 diopters. In certain cases of, say, keratoconus or very expand the range that we have to measure. So that can be done by adding a trial lens in front of the patient's eye. Like it's attached to the machine, so that the light which is being reflected goes through that lens. So a trial lens of plus 1.25 will help us in increasing the range by 9 diopter. And suppose we need to go less than 36, then a trial lens of minus 1 diopter will help in decreasing the range up to 6 diopter. So if we are using these lenses, then whatever reading that we get of the keratometer, suppose we have used a plus 1.25 lens, then you have to add 9 diopter to the keratometric value that you have got. And if you are using a minus 1 diopter lens, then you have to decrease 6 diopter from whatever value that you have got on measurement. Nowadays, most of us are using orthokeratometers like the one from top call. So here the target Mayas are illuminated by infrared light, and they are projected on the cornea. There is no mirror system which is illuminating the cornea. The image is received by a photo detector, which then calculates the size and the curvature of the cornea. The main advantage is that it's very compact and requires extremely less time, and it's very easy to be used in uncooperative patients or children. So the uses are keratometer is helpful in estimating the patient's corneal astigmatism. It helps in monitoring the shape of the cornea in keratoconus. Again, in keratoconus, you can end up with very steep cornea. So it gives us the Myers, if they are distorted, so it gives us an idea that there is keratoconus, and we can then serially measure the keratometric values and follow up the patients. And if in case we don't have access to topographers or pentacam. So it also, keratometer helps in estimating the nature of the refractive error in certain cases when like very small kids or unresponsive patients, or in cases of amblyopia, media opacity, it can give us an idea that what can be the probable refractive error of that person. Obviously, the keratometer is invaluable in calculating intraocular lens power. The keratometric values are fed into the formulas to help us give us the lens power. It helps in determining the nature of ametropia. Suppose there is a patient now, if we get the value, the curvature value we are getting at say 40 diopter. If 40 diopter is there, then we assume that the cornea is a little flat. But if the patient is high myopic, then we know that it is axial myopia. So this way, the keratometer can also help us in determining the nature of ametropia. It is invaluable again when it comes to contact lens fitting. It can help us calculate the base curve of RGP or hydrogel lenses. And these values, once we have taken a baseline measurement, they will always be helpful when the patient comes back to us for change of lenses. Then we can understand whether the lens wearing of the lens has caused any shift in the shape of the cornea, and that can cause changes in the keratometric value. And it is also helpful in monitoring the pre and post-op astigmatism in cases of refractive surgeries, or when we have corneal sutures. It can give us an idea that how do we need to release the sutures so that the astigmatism can be resolved as much as possible. Now, there are certain cases where we have difficult and complex keratometry where suppose the patient is not fixating properly. So in that case, Myers will constantly be moving, and it becomes very difficult to take measurement. So it has to be ensured that the patient is fixing at the light inside, and that is when we can get the proper keratometry value. If there is a poor tear film, again the reflection will be not very good. We'll get all fuzzy central Myers when we see through the eyepiece. So in that case, it's always better that you use a tear substitute and then alignment, ask the patient to close the eyes for some time and then open. The moment we open the eyes, for some time the Myers will be fixated, and that is the time where we have to take the reading. Post-refractive surgery, keratometry has to be combined with topography, and thus it will give us the shape of the cornea in that case. So there are certain limitations of keratometry. The first one and most important being that it measures the refractive status of very small area of the central cornea, just 3 to 4 millimeters, and it does not take into consideration the peripheral area. The posterior surface of the cornea also can uh, is very important, and it can have implications into various results that we get in cataract surgery or in refractive surgery. So keratometry doesn't help us in assessing the posterior surface of the cornea. It is not very effective in the post-refractive eyes because again the shape of the cornea is changed, and the values that we get from keratometry will not be of much use. As I said, the accuracy is lost when we are measuring very flat or very steep corneas. And if there are small corneal irregularities like any corneal opacity, then again that would cause the shape of the Myers to be distorted, and it will result in irregular astigmatism when we are using the keratometer. The one position instrument, they assume that there is regular astigmatism and they will always give the reading in 90-degree axis. So they cannot be used in patients where we expect them to be having irregular astigmatism. And poor fixation, poor tear film, and nystagmus will be giving fallacious readings. So we have to be careful when we are using the machine in such patients. Thank you.
I've got two very simple questions. One is
Yes, sir.
whether this manual keratometry and auto keratometry,
Yeah.
which one is better? And it's always said that manual keratometry should be better. What is your take on it?
Sir, I have always found manual keratometry to be more accurate. But again, we need to have that much time. So if we have optometrists who are doing the biometry for us, I always would love to have the readings from a manual keratometer, because they will be more accurate when it comes to auto keratometer.
I
The
think
second question.
I
Yes,
think
sir.
the area of measuring the cornea is little bigger, larger in cases of manual keratometer than the
Yes,
auto.
sir. Yes, sir.
Yes.
Dr. Madhu, you want to add something?
I think nothing more specific, ma'am. I think sir has covered quite well and comprehensively all the topic. Yeah.
Thank you.
One more question, whether you are putting a lubricant drop in each and every cases.
Yes, I
before
forgot to
doing,
mention that.
manual
Yeah, I do use a lubricant always prior to doing keratometry, because even if little bit of dryness is there, or if the lipid layer is distorted on the tear film, it will cause changes in the keratometry values. And it's always helpful. I have seen that when I do keratometry without peer substitute and with peer substitute, I always get more accurate and reproducible readings when I do it after putting lubricants in.
Yeah, it's now advocated that each and every case should be used the lubricant before going for the test.
Yeah. Thank you.
Thank you. Very nice presentation. And this time day in day out in our cataract surgery procedure, one of the pre-cataract surgery procedure.
Yes.
So now I call upon Dr. Ravi Darvaiya to speak about scrapping. Dr. Ravi, are you there? Please share your screen.
And this is very important. Scraping for the PG. बहुत क्वेश्चन आएगा इस पे.
Yeah. Am I audible?
Yes, yes.
Good afternoon to everyone. Thank you to the Jharkhand Ophthalmic Society for giving me this wonderful opportunity. I'll be talking about corneal scraping. I have nil financial interest, and we all know that the cornea is the most exposed part of the eye, so it is vulnerable to infections, trauma.
Please go to the full screen. Please go to the full screen.
Yeah, it's the full screen, sir.
Okay, please go on. Go ahead.
Select slide mode, Ravi. Select that slide mode on just beside 72% on lower right screen.
Now?
Yeah.
Okay. So as we all know that the cornea is the most exposed part of the eye, and it is vulnerable to infections and trauma, but it also lends itself to diagnostic and therapeutic procedures. Basically, this is what is known as the corneal scraping. So I have nil financial interest in this presentation. Now, the indications for corneal scraping are basically two.
Ravi, there's something wrong. Your slides are not coming properly. I think the last slide is being projected.
Now it's fine, sir.
But
Sir,
it is not.
Can you make it into slideshow? Just a second. Sir, just a second. Can you make it into slideshow, sir?
Slideshow, yes. This is the
just go. Yeah, in the bottom, if you see where there is 72% written, next to that is the small icon, bottom right hand side. Yeah, just click on it.
Click on it.
Yeah, click.
It is not coming.
Just hold on. I'll just
stop share and reshare. You should be able to do it.
Yeah.
First stop. I'm stopping. You can reshare.
You just stop it.
You can reshare now, sir.
Now I will share the slide.
Share screen.
Share screen, yes.
And just select the pop-up will happen. Just select the share button, blue one. आएगा.
अब आ गया.
हाँ, इसको नीचे दोबारा उसी पे क्लिक कर दीजिए. क्लिक करिएगा.
अब क्लिक कर दिया.
नहीं आया सर, चेंज नहीं हुआ.
You can go to the top bar. It's written there, slideshow.
ऊपर, हाँ, सबसे ऊपर चलिएगा, स्लाइड शो लिखा है ऊपर, टास्क बार में सर, ऊपर सबसे
स्लाइड शो,
हाँ, उस पर क्लिक करिएगा सर। योर स्क्रीन,
now it has come.
सर आप या perfect sir,
Yeah,
Perfect. Now it is coming.
So basically the indications are either diagnostic or therapeutic. Now for diagnostic, we use it for in diagnosis of corneal ulcer to find out the infective etiology. Now, what are the prerequisites for a corneal scraping? We need a wire speculum, which is optional. Most people don't use a wire speculum. A good anesthetic agent, proparacaine 0.5% is good enough. Bart Parker knife, glass slides, cover slips, and the culture media. Now, the culture media that we usually use, the common is the blood agar. It is good for aerobic bacteria. It even grows fusarium. It is not good for Moraxella or Neisseria or Haemophilus. For that, we either use the chocolate agar or the McConkey agar. The SDA is used for fungi, and the BHIB is used for the yeast and the filamentous fungi. So these are the preparations that we should have when we are planning for a diagnostic corneal scraping. Now, this is a article by Nepur et al. In IGO, which shows that of all the investigations in the corneal scraping is one of the most effective and highly sensitive investigations, because if you do a corneal scraping, the Gram and Giemsa stains give at least more than 40% of sensitivity. KOH has a sensitivity of more than 90%. You can even send the samples for PCR. The other modalities that we can use is corneal biopsy, anterior chamber tap, or confocal microscopy, but these are not available in all the centers. So the most easiest and most accessible to do is a corneal scraping. So basically, how to do the procedure. This is just a short video. In this, I'm showing, the first thing I'm showing is how not to do the procedure. See, whenever we are doing a corneal scraping, the patient should be relaxed. The lids should be separated well. The Bart Parker knife should not touch the lids. So this is the correct way. First thing, the patient should be comfortable, properly anesthetized. The patient should not have a vasovagal attack. Make sure that a slit lamp is properly oriented. Your hand should be stable. And once you take the scrapings, make sure that you inoculate on the glass slide and on the culture media. In culture media, we make it in C shape so that we can identify the contaminants. Now, many times we see the picture like this when we are doing a corneal scraping. When we scrape this thing, we will not get anything because this is basically a pseudocornea. This is a debris, collection of debris. So when we do a corneal scraping, the first thing we need to do is to remove the debris. So this can be removed easily with a forceps. A sealed corneal perforation or impending perforation is a relative contraindication for corneal scraping, but it can be done if done in a proper way. So over here, we see that once we have removed the pseudocornea, you can see the actual infiltrate over there. So first step is always that we clean off any deposits like the drug deposits or the pseudocornea. Then we go to the two places we have to scrape. First is the margin, the active margin, where the active infiltrate is there. So over here, you can see that the active infiltrate is in this area. So we scrape that area first. Next, we scrape the base of the ulcer. So the edge and the base of the ulcer has to be scraped. Whenever we are doing this, you have make sure that you have properly stabilized the lids and the Bart Parker knife does not touch the conjunctiva or the lid margins. So many times the other indications are when we do it for therapeutic purposes, like this is a healing corneal ulcer, but just to increase the drug penetration, we first remove the overlying epithelium which has come back, and so that the penetration will be much better and the resolution will be faster. As you can see by the photo over here, once we do a therapeutic scraping, in corneal ulcers, it's always better to do a therapeutic scraping if there is the epithelium is coming over. So it results in a faster scarring. Next, Other indications for therapeutic, corneal ulcers are for diagnostic, and for therapeutic, we can use it in recurrent corneal erosions where there is a large area of loose epithelium. Many times we also use epithelium debridement in cases of macrostria post-LASIK just to release the Bowman's folds. In cases of microsporidal keratoconjunctivitis, we remove the epithelium so that it results in faster healing. Another indications are when we have something like this, which is a persistent epithelial defect. The margins are unhealthy, rounded, and edematous. If we scrape the margins, the epithelium will slide and it helps in the healing. Another indication is when we do it for shield ulcers in VKC, when we have to debride the base, so that unless we debride the base, the ulcer is not going to, the epithelium defect is not going to heal. So this is an example of a shield ulcer where we are cleaning the base. So what are the complications of there may be scleral extension of the infection. So whenever we are doing the corneal scraping, we make sure that it touches only the cornea, does not go into the sclera, or we don't nick the conjunctiva or the sclera. Secondly, there will always be residual scarring. That is basically the healing process. Corneal perforation is a possibility. And then cases of endophthalmitis also have been reported post scraping for therapeutic purposes. I'll just show you one of my complications. In this case, where we are scraping, sometimes if you become overzealous, then it will result in a perforation. You can see the fluid leaking from this ulcer. So then in those cases, we just have to make sure that we dry the surface well, have an adequate epithelial defect, and then just place a glue over it and a BCL over it so that the perforation closes down. So whenever we are placing the glue on the eye, in cases when we have some complication like this, that the ulcer perforates and this thing, make sure that the surface is dry, there is adequate epithelial defect so that the glue holds on. Try to put a thinnest layer of glue as possible over the area. So this patient, like, he had a perforation and it healed perfectly well after 6 to 8 weeks. So corneal scraping is not useful in certain cases. Like example, when we have deep stromal infiltrates like this one, when the active infiltrate is away from the cornea into the endothelium or into the AC. In these cases, it is more logical to either do a anterior chamber tap. Other cases where corneal scraping will not help much is when we have a stromal pathology, something like an infectious crystalline keratopathy. In these cases, most of the time corneal scraping does not yield any results. These usually require a biopsy to confirm the infective agent. Other cases are when you have cases of suspective endothelitis, CMV endothelitis. You have this classical ring coin-like lesions. So in these cases, the diagnostic is by AC tap. Many times when like this patient presented with a thick plaque ulcer, like a fungal ulcer, but when you see it closely, you see a reflection out here. This is basically a BCL which had a lot of deposits over it. So you get various clinical presentations. So the takeaway message is that corneal scraping is a very simple and useful tool for the clinician to reach a diagnosis, and when used for therapeutic indications in the correct way, it helps in the early resolution of the disease process. Thank you for your kind attention.
Any question from anyone? If there is none,
sir, yeah, just 1 second. One question, Ravi.
Yes,
so
ma'am.
if it is, have you ever used a thread?
Thread.
When it is a deep infiltrate,
Yes.
any suture. So would
Yes.
you like to tell the PGs about that?
Okay, when sometimes, let's say you have a very deep posterior stromal infiltrate. In these cases, what we can do is that we can pass a 10-0 or a 8-0 vicryl suture through the needle, through that area,
Yes.
without perforating it. and then you can place it in the culture media. We have done it earlier. We used to do it. Yes.
Yes. So that is very rare of rare circumstances where you don't want to do a biopsy. So you can pass a thread and that will be good enough. Otherwise, you have covered most of the things.
So now I request Dr. Bharti Sharma to share her presentation. She will be talking on corneal topography.
Yes.
You want to add something?
Yeah, I think excellent presentation by Ravi sir, madam. The only thing is, while doing the scrapings, as he has rightly pointed out, we should remove the slough. When you take out the slough, you only get pus cells. So once that slough is removed, you have good microbiological things that you can have a better yield of microbiology in the slides. And whenever the material is less, I prefer to do give the material for gram stain and blood agar, because these both cover 90% of the organisms. And in that order, we can prioritize the other cultures and this thing. And one more practical thing is, maybe for beginners, it's better to use the upward strokes, where you can see the material getting accumulated on the blade rather than downward strokes.
Okay, so upward stroke is more important.
Yeah, very practical tip.
Yeah.
Yes, very practical.
Very practical tips. Yeah, Dr. Bharti, please.
Yes,
Dr.
sir.
Bharti Sharma.
Yes,
Please
sir.
share your presentation.
So my screen is visible?
Yeah, very much.
So, yeah. So good morning, everyone. I thank Jharkhand Ophthalmological Society for giving me this opportunity. So I will be just covering, so keeping in mind that this is basically a post-graduation session. And after me, Dr. Madhu is going into details of the pentacam. I am just going to take the residents right from what we were doing in topography earlier, from the older methods and what we are doing now. So I'm not going into too much details, but I'm giving them an outlook so that they can go and stimulate their minds and they can read it further. So corneal topography is basically a special photography technique that maps the cornea. And the word topography comes from a Greek word. Topo, we all know, is a place. And graphing means to write. This means basically to describe a place, and topography is the study of the shape of the cornea. So why this is important? Because we all know that nowadays imaging techniques of the cornea are developing rapidly, mainly because of the recent advances in refractive surgery. And all of the ophthalmologists are under a constant pressure to improve their safety, efficacy, and quality of their outcomes. So outcomes are the main thing. So how it was all started, just to give a history, that Antonio Placido da Costa, he was a Portuguese ophthalmologist and a microbiologist. He first introduced a handheld device. We can see the shape down to precisely evaluate the corneal shape, and published his report in 1880. The tool he used was of diameter 23 centimeter, which had concentric black and white circles with an opening in the center. He made the patient to stand in front of the window, and the corneal reflex from the keratoscope was to be evaluated at a distance of 15 centimeter from the cornea. So not only our earlier based Placido disc topographers, but even the most of the latest topographers we have still employ this Placido disc principle. So, but in addition, they have a small image registration, which they have a video keratoscopy, a small video to monitor all the readings. So we should remember, I'm skipping off all the earlier Placido-based, the earlier ones, because they are obsolete. So I'm coming to what we use now, how we can use this technology in the most modern machines today. So they are basically a large cone-shaped or small cone-shaped system. The small cones, they collect more data and they are more accurate. But however, the drawback of these are they have a very short working distance and very difficult to collect data in patients with deep orbits. So basically what we have today is the large cone topography system. Very few are the old, one second. So very few are the small cone ones. And we also have something which is known as color light emitting diode. So the large cone topography systems can be seen in the modern ones like Sirius oculus keratograph, the Topcon, the Zeiss, Atlas, and Zimmer Galilei. We have all seen this. Most of the optometrists will see these machines when they go to any of the higher centers. The small cone topography system, not so much. Opticon Keratotone. So we have something which has come up recently is Cassini. So this Cassini basically has diode, color light emitting diode points, which goes to the cornea, and that is how the images are studied. So we will go in it by one. So in addition to, just to mention that the Placido disc principle is not only used for the topography, but it is also used to analyze the tear film. Again, I'm not going too much into detail. Dr. Pooja has covered it up very properly. So we have this oculus keratograph. So it is also used, you can see the Myers are used to see the tear film of the patients. So dry eye evaluation is one of the other uses of it. So corneal topography also has to be used along with the aberrometry. We are all aware of all the latest papers, publications are on eye trace. Eye trace is a very beautiful scanning system, which is from USA. And they used in these devices corneal topography and the wavefront map. They can be linked to each other, which enables us subtracting the corneal aberration from the total eye aberrations. Also, these devices provide repeated measurements of the near and distance spherocylindrical refractions. So not only these devices give you very good about the angle kappa also, and it gives you an estimate whether you should be able to use the higher end presbyopic IOLs, but it also gives you the aberrations of the eyes. So both the factor, but these rely only on the anterior corneal topography images. I'm not talking about the posterior corneal layer. I'm not talking about the tomography. So tomography is something different. I will come to it now. So these are the eye trace. All these things, they rely mostly on the tear film, the Placido disc principle. So what is color-led topography? So this is what I was talking. This Cassini corneal topographer is able to analyze the corneal shape based on point-to-point reconstruction of the specular reflections of 679 pseudo-random colored points. You can see the diagram there. The potential advantage of this approach over the Placido-based system is that it is not affected by the Placido mismatch, resulting in the proper reconstruction of the non-rotational symmetricals or even the distorted corneal surfaces. So there are a lot of studies recently on this machine. And we can see that what they have concluded is that the magnitude of corneal astigmatism, which was obtained with the Cassini topographer, was not different to that of Pentacam, the Lenstar, and the Keratron. The repeatability of the cylindrical measurements was very high than with the Pentacam or Keratron. Basically, so they saw that the readings of astigmatism were very, very accurate. They also claim that the colored LED topography also enables the evaluation of the posterior surface using the second Perkinse image technology, because till now Pentacam is the gold standard, but this also is supposed to give equally good results. Lot of studies, as I said. So this is one of the study which I found that what basically they did was that astigmatism analysis measurements from the anterior cornea was obtained with the color LED topography. It showed excellent agreements with the Pentacam measurements. But the agreement was poor for corneal posterior surface and particularly the magnitude of astigmatism. So they concluded that the corneal refractive power and astigmatism tends to be higher when you measure them with Cassini than with the Pentacam HR in both the anterior and the posterior cornea. The two devices might not be used interchangeably, but they said that the astigmatism, the correction was a little higher than the Pentacam. So we come to the most widely used instrument, which is there in most of the clinics, that is Pentacam. So Pentacam basically works on the corneal tomography. Tomography basically derived from the Greek words cut. Tomo means cut section and right means graphic. So this allows a generation of stereography model of the cornea and enabling the analysis of front and the back surfaces of cornea along with the pachymetry mapping. So what are the devices which use the corneal tomography? That is, it not only scans the front surface but also the back surface of the cornea. And also we have other devices which even nowadays they measure the axial length of the cornea. So the old one was scanning slit laser, which was OrbScan 2, where the source of the light was white light. The Chemflux technology is basically in series Pentacam Galilei. It uses the blue light emitting diode laser. OCT technology is used in Revo, and the latest one is the SWEFT source OCT, which uses the laser with longer wavelength. We are getting this Heidelberg Anterion. We have it in Zeiss Visante. So we will take it. The main ones, basically, what is important? OrbScan is obsolete. Pentacam, very much there. Galilei is there. Sirius is there. All are Chemflux-based technology. So all of us have to, also by the time you people will graduate and, come into the field, the way forward is always the OCT. So we are now coming up with MS39 and Anterion. These two are already in the market. Very much there. A lot of higher centers have it. So let us see what was OrbScan. The OrbScan device, basically, this is the old one. So it employed the slit scanning laser and it calculated the corneal curvature based on the calculation of the front edge of the slits. The images were not displayed. So they also had OrbScan 2 where they incorporated the Placido disc. So the photo up is of OrbScan 2. So you can see that this is now being taken up by Pentacam. So this Pentacam uses a different method. I'm not again going into details how to read the maps. Dr. Madhu is going to cover it. So basically Chemflux imaging, which is based on the Chemflux principle. So basically Chemflux law says that in order to get a higher depth, you have to move the three planes. That is the image plane, the object plane, and the picture plane. If they intersect at one point, the depth of the focus will increase. So this principle is used and Pentacam in Pentacam, and basically elevation-based diagnostic system, very accurate in diagnosis of keratoconus, 50 images, less than 2 seconds. Already one speaker has spoken about this. So direct measurements of the power of the cornea. So again, details will be with Dr. Madhu. So just to show you what Pentacam in images looks like. So this is one patient and this is the scan. So the scan, you will have all the patient's data, the quality index, what are the K values, so and what are the anterior chamber depth analysis and different type of maps. So the most common map, this is the sagittal map, the front surface, the anterior and the posterior. So these are the elevation maps. These maps are the addition ones, which were not there in the earlier systems of the Placido-based system, where they used to give only the sagittal map. So now we are getting the elevation maps and the pachymetry map. So we also have this anterior chamber depth maps in Pentacam. Basically, they will also give you whether you can do the phakic IOLs and or not for the patient. So you can also, consult the patient densimetry evaluation, whether the cataract and all is there. So you also have phakic IOL software, contact lens fitting. So something which is very new and exciting, and if you all have heard Dr. Rohit Shetty keeps on talking about this, is MS39. This is an anterior segment OCT machine. This is a very must-have for all the LASIK surgeons. It is the most advanced device for the analysis of the anterior segment of the eye. It combines the Placido disc. You can see the rings are there. Corneal tomography with the high resolution OCT-based anterior segment tomography. The clarity of the cross-sectional images with the 16 millimeters diameter, along with many details of the corneal structures and layers. So it images layer by layer of the cornea, and the most important thing is it images the epithelial layer very well. So it gives you information on the pachymetry, elevation maps, curvature and dioptric power of both the corneal surfaces. So the most important maps are the epithelial and the stromal map. So MS39 includes the advanced measurements of the epithelial and the stromal layer. We all should know that there is epithelial masking effect, so that the morphology is very useful in the abnormalities of cornea. So whenever there is a thinning in the corneal stroma, for example, early cases of keratoconus, so what happens is, in many patients, what they was found out was there was a compensatory thickening of the epithelium. So whether to know there is a progression of keratoconus on Pentacam, even if it's showing progression of keratoconus, and there is no progression on the epithelial maps, or the elevation maps are stable in this MS39, you can wait and watch. So this is a food for thought. And I think slowly our Pentacam, along with it, we would have to look at the epithelial mapping and the stromal maps on the OCT also. This is a complete game changer. So you additionally, it gives you the aberrometry maps, which is the aberrometry analysis offers a complete overview of the corneal aberrations. So it is possible to select the contribution of the anterior, posterior, or the total cornea for different pupillary diameters. So this can help the clinician to understand and explain the patient's visual problems. You also have keratoconus screening program in MS39. It provides the clinicians with important information about the patients with cornea and can help prevent complications associated with ectasia before the corneal surgery is undertaken. We are all afraid of post-LASIK ectasia. So all these machines help us to prevent it. So just in last, I'm talking about anterior. This is from Heidelberg, Germany. It is also a very excellent machine, and this gives you not only, it has various modules, not only the cornea, it also gives you the axial length of the patient. So this combination of high resolution OCT images and the corneal measurements, thorough assessment gives the curvature and elevation maps of anterior and posterior corneal surfaces. They claim you don't need Pentacam, and anterior itself is good enough. So total corneal power, pachymetry, and corneal wavefront analysis, this gives a clear information. So basically it has a ectasia view and score analyzer. So ectasia view, this provides a comprehensive tool set to aid in the assessment of the ectatic changes of the cornea. So what is SCORE? It is screening corneal objective risk of ectasia, very unique visualization and analysis tool that assists in the evaluation of keratoconus and other ectatic diseases. So it combines multiple corneal indices that helps in magnitude of corneal steepening, thinning, and asymmetry. So these are briefly the SCORE analyzer, and you can see that all the different scores are there, and it will give you an estimate. Basically, all these are used to see whether a patient, you can do a refractive surgery, whether the patient has keratoconus, all those things. So these are something, all of you, if you have, if these machines are not available in the places, you can easily go then attend in All India Ophthalmological Society conference. You can go to the trade hall. All these machines are there for display. So I have also learned from there and attending the conferences. So we have this NIDEC and Tracy eye trace. This NIDEC OPD scan and Tracy eye trace basically use only the anterior corneal topography and the ocular aberrometry. So LensStar, many of the clinics would be having, and Topcon Aladdin, again the topography, but they also give you the additional ocular biometry, very, very accurate. We have Pentacam AXL, which has corneal tomography and biometry, Zimmer's Galilei 6, and you have corneal topography, biometry, and the posterior segment OCT also coming with the Revo NX. So all these machines are there. Some you would have seen, some you would definitely, you should go and see and decide for yourself what you would like to have in your practice. So to conclude, there is a wide variety of imaging techniques to obtain the corneal power maps. As different technologies are used, it is imperative that doctors involved in the corneal surgery understand the science behind it and the clinical applications of devices for corneal evaluation in depth. Thank you so much.
Any inputs from anyone? Dr. Madhu, please.
Sir, I think an excellent presentation. Madam has covered almost all the available topographers, tomographers, and other combinations that are available in the market. Nothing specific to add, sir. The only thing like a clinician we have to see is you have to know what is the sensitivity and specificity of that particular thing. Because sometimes when the sensitivity is more, you are more likely to pick up false negatives. So I think you should spend on the technology that is more specific rather than sensitive. That's the only point I wanted to add. Yeah.
So now I invite our secretary, Dr. S.K. Mitra, to introduce Dr. Madhu. He's to our local speakers and the participants.
Good afternoon once again. I just a hearty welcome to Dr. Madhu Udaraju. He has spent the Sunday morning as well as spending the afternoon also with us.
Yes.
Very warm welcome to you to our forum. He'll be speaking on reading pentagram. But before that, I am just introducing Dr. Madhu to you. He is Dr. Ramanas Rajiv Bhishan is the chairman and managing director, UVSM Eye Hospital and trustee, Bhimavaram, the co-chair and trustee, and he is the chairman scientific committee of Andhra Pradesh Ophthalmic Society. He is the advisor of Indian partners of the Harvard Global Alliance for Medical Innovation and Orbis Cybersite volunteer faculty, ISM SICS Andhra Pradesh chapters honorary general secretary. He has done 2200 plus corneal transplants, 1800 plus refractive procedures, and 30,000 plus cataracts. A long list, and the long list is going again, is on to go also. There's a mentored 12 long-term and 6 short-term cornea fellows, mentored by Dr. M. Srinivasam and Dr. Venkatesh Prajna from the Arvind Madurai. Refractive surgery accreditation from Singapore National Eye Center. He is the international fellowships from Unimore, Italy, universities of Sweden and Harvard, USA. Developed Cornea View for the corneal donor tissue evaluation, and the first to perform Bowman's layer stromal transplant for the advanced keratoconus in India. The American Academy of Ophthalmology International Education Award 2020 and International Scholar Award 2022. All India Ophthalmology Society LDP graduate 2014 and the International Heroes Awards in 2019, 2021, 2022. Wow. Best paper in APAO 2019 and best video AAO 2020 and best paper ACRS 2022. 82 free papers, 28 posters, and 106 invited talks. Rare record of winning all 7 named gold medals in Andhra Pradesh Ophthalmic Society. Sri Kiran Best Paper 2015, Vasundaram Best Inter-Segment Paper, and G.R. Reddy Best Paper of Conference 2016. Ragvachar Best Paper 2017, Bengal Raju Best Paper in 2018, Nayan Sriram Best Paper, and Akira Prabhakaran Best Video 2019. 8 publications in international peer-reviewed journal. A long way to go. This is the short synopsis, actually, I know. So I invite Dr. Madhu Udaraju to talk about the reading Pentacam. So Raju, please.
Thank you so much, sir, for the kind introduction. It's a great honor to be speaking at the Jharkhand Ophthalmic Society PG program. I personally congratulate all of you for conceiving such a wonderful program. I have been listening to most of the talks. They're very practical and PG oriented. I think we'll take a clue from Jhos and also implement it in APOS. Thank you, Bharti ma'am, especially for making me part of this, and Mitra sir for allowing me to be part of this wonderful program. So without delay, I'll go into the presentation. I know I'm standing in between you and your Sunday lunch, so I'll try to keep it simple. And my screen is visible, sir?
Yes, it is visible.
Okay, right. So I think the topic given to me was Pentacam reading. So I think mostly for postgraduate level, you get a Pentacam in your Viva as part of your examination to read the Pentacam. So I'll try to keep it as simple and practical as possible. So the scope of this talk would be under the following headings: the principle of Pentacam, reading a Pentacam report, what are the ectasia criteria, and what are the red flags that we have to see in Pentacam, and also I'll mention about the Bellin embouchure ratio that comes on the backside of the printout. So I think previous speaker has very nicely pointed out the difference between topography and tomography. So if you see topography, it covers only the anterior surface. We get only the sagittal map and the local map. Whereas in tomography, both the anterior, posterior surface is covered. So we have an elevation map and also the thickness map, which gives us more data regarding finding any early ectasias. So why Placido disc-based topography is not enough? As I've already told you, it only measures the anterior part. The data such as posterior surface, power, elevation, pachymetry are not measured. And there is a high risk of missing out a form thrust keratoconus, which can be disastrous, especially when you're doing a refractive surgery. So the principle, I think already madams have covered, so I'll not go into much detail. So it is like we have 50 meridional sections captured from 2 cameras. The highlight of this particular technology is the center is always maintained. Though the camera is rotating, the central point is maintained. Thus, we have a good value thing that we get it in the printout. So coming to the refractive maps, so these are, if you see the refractive maps, there are 4 maps that you can see. So one is the front sagittal curvature or the corneal curvature map. Then you have elevation of the front, elevation of the back. So there are 2 elevation maps, and then you have a pachymetry map. So this is the quad map that you see commonly in most of the printouts. So now, how are these maps measured? So if you see, the pink colored thing is called as the best fit sphere, whereas the cornea is not as a best fit sphere. So there is always an elevation and depression that can either be above it or below it. So depending upon that, we color code the images. So elevation is represented in default of color steps. So the best fit sphere would be in green. So it is similar to our globe. So whenever there is a area that is lower of thing, it is like the seas, they are blue in color. Whereas you have a high terrain, they are warmer colors like orange and red. So this is how the color should be coded on the color map. So, and one more important thing that we see in Pentacam when compared to the older machines like Orbis is, the Orbis compares it to best fit sphere. Actually, the cornea is not a best fit sphere, but it is a best fit ellipsoid, because the corneal prolate shape is more nearer to a best fit ellipsoid. So here all the parameters are compared to the best fit ellipsoid rather than the best fit sphere, which is an older concept. So now once you see these 4 maps, look for these patterns. Try to identify which kind of pattern are you seeing in these color maps, especially in the elevation and pachymetry maps. So most commonly what you see is this round pattern, oval pattern, superior steepening, inferior steepening, irregular. Then you have a bow tie, which is symmetrical. Then you have a bow tie, which is symmetrical with skewed axis. Then you have an asymmetrical bow tie, superior and inferior. And then you have an asymmetric bow tie with skewing. So 2 most important things or patterns you have to identify are, one is asymmetry. So whenever there is an asymmetry and whenever there is an inferior steepening, these are the 2 important things that you should have a maximum suspicion for ectasia. So of all the patterns, always look for asymmetry. So whenever you see asymmetry, and asymmetry, especially in the inferior part with associated steepening, where have a very high suspicion for ectasias. So now coming to the points that we have to see in reading these maps. So first thing I told you is the sagittal map. So in the sagittal map, what you should ideally look for is, again, symmetry. Coming to the elevation, both anterior and posterior, make sure that this anterior elevation and posterior elevation again are looking similar and there is no displacement, especially in the posterior part. And again, pachymetry profile also should be well centered. So symmetry, no displacement, and well centered. So 3 things that you have to look at is whether the sagittal map is symmetric. Next, you go to the anterior elevation, posterior elevation, and look for any islands of displacement. And the pachymetry map, see whether the pachymetry map is centered, well centered, and there is no decentration of the thinnest point. So these 3 things you have to look for. So these are the things that you can find in the textbook. So I will not go into much details. So I have already told you in the sagittal map, look more for the symmetry. So whatever this SI difference or ISI difference, whatever these all things will be pointing more towards symmetry. And in the same thing, thickness map, look for the centeredness. And in the elevation maps, look for any displacement. So now I'll cover the most important red flags. These are the 8 important points you have to remember while you are looking at a printout. So first is look at the elevation values in the front. So elevation values in the front, if they are more than 12, it is definitely a risk for ectasia. Any value that is in between 13 and 15 are suspicious, and a value of more than 15 is considered to be a risk factor. Okay. And in the same way, now coming to the back surface, the elevation of more than 18. If the elevation is more than 18, it is abnormal. So 18 to 20 is suspicious, and value more than 20 is definitely keratoconus. And also the third important point is the difference between the back and front. The back and front should not exceed 5 at the same point. So you are looking at the map at an identical point, and if there is a difference of more than 5 at the same given point, then definitely it is a sign of ectasia. In these cases, you should not consider for corneal refractive surgery. The fourth point is look for isolated islands, either in the back elevation or front elevation. And in the keratometric map, as I have previously told you, look for a superior-inferior asymmetry, and also compare the thickness at the apex and the thinnest location. So the thickness at the apex and the thinnest location, if the difference is again more than 10 microns, you should have a strong suspicion towards ectasia. And in the same way, inferior-superior difference in the central 4 mm zone, if it is more than 30 microns also, it is definitely abnormal. So the difference between the examined cornea and the other fellow cornea at the same point should never be more than 30 microns. So left eye, right eye, you are looking at an identical point and the difference is more than 30 microns, it should have a high suspicion of ectasia. So you see a hot spot in right eye and you want to know whether this is really a hot spot or it is a steepening, then what you have to do is immediately compare with the printout of the left eye and see whether the difference of that hot spot is in less than 30 microns or more than 30 microns. If it is more than 30, have a high suspicion for ectasia. So now what are these hot spots? So when you see a corresponding point in an anterior sagittal map, pachymetry map, and the posterior elevation map. So if you have a corresponding hot spot in all these 3 maps, it is more likely to be a form thrust keratoconus, which you have to address in a orderly fashion. So now I'll just tell you the example. So if you see here, the front elevation is 14. So it is definitely above 12. So it is abnormal. The back elevation is 20. So it is above 18, again abnormal. Again, if you see the pachymetry value is 434. So the corresponding steep area in back, front with low pachy, definitely suggestive of a form thrust keratoconus. So this is a keratoconus screening module that you have specifically again in Pentacam. So it is inbuilt. So what you have to look here is again the keratoconus leveling. So if you see here KK 2 to 3, this is the level. And all these indices that you see here in red are supposed to be abnormal. So now coming to the behind of the printout. Now whatever quad map we have seen is in the front surface along with the data. Now, when you turn around the printout, you come across this Berlin-Ambriscio ratio with CTSP and PTI. So if you see here, again, there are 6 maps. One is the elevation front, elevation back, and then there is the exclusion maps of 3.5 millimeters and 3 millimeters centered on the thinnest point. So it is not centered on the corneal center, but centered on the thinnest points. Then you have the front difference and back difference. Now I'll tell about this in detail. So these are the elevation maps of back and front. This we have already discussed in the quad map. Though what is this exclusion maps are? So exclusion maps, what it does is instead of taking the corneal center into consideration, it will take the thinnest location as the center and draw exclusion maps of 3 millimeters and 3.5 millimeters around it. So whenever in this, again, if you see, the green areas are difference of less than 6 microns. And again, 8 microns are less than 8 microns. These differences are normal. So any area, if you see, there is a difference of 6 to 12 on the front surface and 8 to 20 on the back surface, it should give rise to a suspicion of keratoconus. And in the same way, anything that is more than 20 and 12 and 20, this is already we have explained. So these, the first 2 points will help you to identify very early keratoconus. And next, coming to these representation, one is the corneal thickness spatial profile, and next is the percentage thickness increase. So CTSP and PTSI graph provide information which allow the clinicians to differentiate between the normal thin cornea and an early ectasia disease. So this is how they're useful in differentiating a thin cornea with an early ectasia. So these are the things that you have to look for in the topography. Now coming to refractive surgery index, if you ask me the criteria that you have to look for, like a general or a comprehensive ophthalmologist, there are 3 scores that I usually follow. One is the Randleman-Ectasia scoring system. So in the Randleman-Ectasia scoring system, if the score is more than 2, I usually call it moderate risk. And if it's more than 4, it is a high risk and we do not perform LASIK. And the percentage depth of how you see is first you see the topography patterns. So FFKC, inferior steepening, asymmetric bow tie, and these are all, as these things go, the scoring keeps increasing. So one is on topography pattern, next is residual stromal breadth thickness, next is age of the patient, next is corneal thickness, and this is the diopters of which you are going to correct the power. So taking all into this table into consideration, you can give a scoring. So anything above 3, try to avoid in those cases. Next, you have one more criteria called as the Rabinowitz-Macondal index, where the central K, if it is above 47.2 and the inferior superior asymmetric value is more than 1.2, and also the skewing of the asymmetric bow tie is more than 20 degrees, in such cases, it is better to avoid any refractive surgery. So that finishes the talk. I think, thank you for the wonderful opportunity. I'll be happy to take any questions now.
Now the topic is open for discussion. Any questions and any inputs? Dr. Madhu is here to answer your queries.
So, hello, am I audible?
Yes, ma'am.
So, what about the inter-eye symmetry? Like there should be a inter-eye mean anterior keratometry. If you take, it should not be more than 0.3. If
yes.
The posterior keratometry should not be more than 0.1. Thinnest fatty, both eye difference should not be more than 12. The front elevation at the thinnest location, if you take both sides, it should be more than 2. And the elevation at both the side, thinnest location, if you take back surface, both sides, it should not be more than 5. So what about the inter-eye symmetry you would like to comment?
Yes, ma'am. Inter-eye symmetry is, as you have mentioned, very, very important. And it becomes more important, especially when you find a hotspot. When you find a hotspot in a single eye, never go by that reading alone. Always compare it with the second eye. And as Madam has highlighted, if the differences are very low and if it is symmetrical, it is less likely to be ectasia. If the asymmetry is more, then your suspicion should be more towards an ectasia.
But does it show posterior keratometry? What we see, that is the anterior value.
Yeah, anterior value is what we see in the curvature map, madam.
Yes.
Yeah, but in the posterior power, we don't get it here. We only get the true power.
That's what I'm asking.
Yeah.
The power inter-eye symmetry, they mentioned the posterior keratometry. The keratometry we don't get. We get only keratometry.
Yeah, we don't get it in the map.
Practically speaking, when we do inter-eye symmetry, So we have to see the anterior keratometry. We have to see the thinnest pachy, both height difference, and the front elevation, thinnest location, and the back elevation, thinnest location.
Yes, madam. Yes.
So, okay, the front should not be more than 8.
8 and back. Yeah, back should not be more than 12 and 8. Yes.
12 and 18.
12 and 18.
No, I'm not talking about that. So the interior elevation should be at normally it should be 12. If it is more than 15, it is suspicious.
Yes, madam.
And back should be 17. If 18. It is 17, it is suspicious.
Yeah. Yes.
There's
yes.
one more value. They say 8 and 18, 8 interior, 18 posterior, and for a hyperopic 7 and 28.
Yes, madam.
What is that?
Hyperopia, we need not consider more on the mapping, madam. Hyperopia, because the values you get are more in the periphery. They are not as accurate as the 4 and 6 millimeter radii, and there could be artifacts. So for hyperopias, I'm not as much worried as in myopia when you take into this guidelines.
Is it important to take the see the exclusion map?
Yes. Exclusion map should be taken. The difference map you saw on the back side, no, madam? That
Yes.
gives more value.
Yes. Yes, but this is very important for the consultants also.
Yes, yes.
Because all the time you cannot depend on the PGs. Yes.
So, yeah, Dr. Madhu, one question I have, that
Madam.
sometimes you see patients who have, you follow them for years, they have stable refractions, the refraction is only -2, but they have on balance enhanced ectasia display only shows a little elevation, a little, red area, a little elevate, but their actual back elevation is quite normal. So what do you do for these patients? Do you recommend LASIK? They have very good thickness. They
Yes.
have no other problem. So, and they are young girls, 22, 20, and stable refractions. You have their records, let's say 3-4 years. So often, at least I get very in a dilemma. So what should we do? We should recommend
Madam,
them or
yeah,
any
yeah.
other?
Based on only BAD, we need not reject them, madam.
All right.
You have, because you take into consideration, as you told, they have stable refraction.
Yes.
Their pachymetry values are stable.
Yes.
So in those cases, only based on BAD, we need not reject them.
Okay. So
I
PRK,
usually go ahead and do the surgery.
even LASIK, PRK would be a safer option than.
Yeah. Yes, ma'am. I think
PRK is very painful.
No, but it is safer for the long term. If you see young girls, they will be having.
Yeah.
They will go for pregnancy, and then hormone induced, they can have,
Yes.
ectasia that time.
Yeah.
So that is what I think. I recommend, usually I tell them to go, if their power allows, to go for
Yes.
PRK to be very, very safe.
Yeah.
And one more thing, what is this ART max? How are these values important? On Pentacam, you see this ART max one.
Yes.
So how do you see that?
I don't give much of clinical importance to them, madam.
Yes.
And mostly what I follow is, as I've told you, to be practically only 4 things I see. One is the color thing. I look for hotspots immediately.
Yes.
And look for any asymmetry.
Yeah.
And any pachy that is below 400, and patient-related issues, like you have told, the hormonal thing or any unstable thing, and if you have very high expectations.
Right.
All these, whatever you are telling them, they become very sensitive.
Yes.
Like if I use them sometimes to deny a type A patient that you are not suitable.
Okay.
Otherwise, you can go ahead.
And do you see the difference of astigmatism? Like, suppose the astigmatism is showing here 180 and the patient is accepting 160. So do you see, or it is not a major point?
Yeah, dilated whatever refraction we do and patient is accepting is only what we take into consideration.
But when we do LASIK, when we do pre-op evaluation, we do dilated aberrometry. We rely
Dilated refraction also we can.
yes, dilated refraction, and we try to see how much the dilated refraction cylinder matches the abrometry.
Yes,
we
madam.
Oculizer dilated. We see the dilated abrometry for cylinder with dilated refraction.
Yes, madam. Yes.
Okay, so I think this part is not that important. The
Yes.
difference between the
more whatever patient accepts, and dilated AR, dilated refraction is more important.
Once we are in busy OPD, we cannot concentrate half an hour for the oculizer report. We have to see the hot spots. We have to see the color map, the symmetry, color map, the thinnest pachy, and
one more practical thing, ma'am. Like whenever you have a doubt, there is an option for you to decrease this gradient. These color steps are usually at 0.5 diopters or 1 diopters.
Okay.
So if you are having a doubt in particular area, you can go back and make that diopter to 0.25.
Okay.
So then that spot will elevate even further.
Okay.
So that gradient thing is also adjustable. Whatever comes by default usually will be 10 microns, 20 microns in pachy, and in dioptric power it will be 1 diopter or 0.5.
Okay.
Sir, I have a question. Sometimes like we have patients, young kids, wherein even if I'm doing dilated refraction and whatever reading the autorev gives, when I'm doing retinoscopy, I get slightly different. I mean, the acceptance is slightly different. Even if I'm getting the retinoscopy, the acceptance is slightly different. The axis is generally 10 degree here and there. So in such cases, should we do a pentacam? And if we are doing like, what are we looking for? What help can it give us if in such cases where the acceptance is different?
What is the age, sir, of the patient like?
I'm talking of adolescents, sir. I'm not talking of adult. I'm talking of kids from say 9 to 15 years of age, that age group. So if the acceptance is not matching with the AR values that we are getting from the computer, so should we go for a pentacam?
I would not say immediately, sir. Whatever the patient is accepting, we can give.
Okay.
Not in all cases that we need to go for a topography. And in these cases, you get better things when you use a Placido-based system rather than the Scheimpflug.
Okay. So this difference would not be because of the posterior corneal surface. It doesn't happen that way.
No. Very rarely it happens, sir. It most related to ocular surface itself.
Okay. And in case like nowadays kids are using so much phones and all, we are seeing myopia progressing a lot. So what is the earliest age where we can start using pentacam to monitor any change in
Sir, I think, now most of the systems have come with this axial length measurement.
Okay.
And there is a table that tells you, depending upon the age, what should be the axial length.
Okay.
And axial length changes, again, they grade into different grades. And whenever you see that is something called as now pre-myopia. So in these cases, now they are starting to use low-dose atropine even before.
Yeah.
But the most important thing is, along with medications, the counseling that they should have some 1 hour of outdoor activity, because all these are more related to their near work. So counseling of avoiding phones for a longer time. So it's more like a public health issue now. What you have told is very true.
Yeah, that is true. But like I have seen a couple of kids, they are 7 years of age, 6 years of age. They came with headache. And when I did refraction, I'm getting cylinders up to 3.5 diopters of cylindrical power. And unaided vision was somewhere around 618 or so. But with so much cylinder, they are going up to 6.9 partial or 6.9 at the most. Now, such kids, 7-8-year-old, should I do penta? Will it help in any way to understand that whether the cornea has already started becoming weak? Or is there...
By default, any cylinder more than 1.4, you have to do topography, sir.
Okay.
Any cylinder, it is more than 1.5 diopter, it should rule out ectasia, especially in children in growing age. So that you can do, sir. And these, especially these mobile related things, first we have to also look for this convergence insufficiency also. Most of them with this convergence excess, not minus 3.5 and all. I'm just speaking about this -1 sphericals and all.
Spherical power,
Rather than directly going to glasses, we have to rule out this insufficiency and this conservative mechanisms first before going to prescription. But -3 cylinder definitely warrants a topographical evaluation, sir.
Thank you.
Yes,
I want to ask one thing. Hello, am I audible?
yes, madam.
So this inter-eye symmetry is important or not?
It is important, ma'am.
To scoring 1, 2, 3, 4.
Yeah.
So is it important?
Yes. Inter-eye symmetry is important, especially when you are seeing these hot spots, ma'am. Not in all the cases. In form first keratoconus, always you have to compare it with the other eye.
Yes.
And also inter-eye asymmetry, also you have to look for the refractive error also, ma'am, whether it is asymmetric or symmetric.
Okay.
That cue also you have to take, yeah.
Okay. So it was nice. You took so much of pain, and I really was not only delivered your lecture and disappeared, but you were present, just like my secretary. Firstly, you were present. This time I'm really thankful to Vivek Kedia and Bharti Sharma. They also are present continuously. And Dr. Utpala is there, ready for the vote of thanks. So request Dr. So once again, thank you so much.
Thank you.
Madhu Raju. So for imparting so much of knowledge. And now over to Dr. Utpala for vote of thanks. She is the head faculty of CCL and Coal India. And they have a lot of DNB students. And every time I watch her DNB students open their video camera.
Please open the
Yeah, DNB
A very warm good afternoon to one and all. As we come to the conclusion of the program, I wanted to take a moment to express my sincere gratitude for this wonderful training workshop. To our keynote speakers, thank you for sharing your valuable insights and expertise with us. The knowledge that all the participants gained from the sessions were truly invaluable, and I know that they will be able to apply them in their personal and professional life. Your passion and expertise in the subject matter were evident throughout the workshop, and it was a pleasure to learn from you. A special thank you to our guest speaker, Dr. Madhu Udaraju, and to Dr. Bharti Kashyap and her team. The coordination and planning of the event were commendable, and I appreciate all the hard work and effort that went into making it a success. Also, thank you Entourage Pharmaceuticals for sponsoring this event. Your support and generosity were instrumental in making this event a grand success. Once again, thank you so much for your time, dedication, and contribution to the personal and professional development. Thank you.
Thank you. Thank you all.
Well done. Cornea PG webinar finishes. Dr. Utpala, please send me the report.
Bilkul, promise.
Because I have to submit, because I want to wind it up, because we have to be focused on the conference. Please, report bhejiye. And thank you, Utpala, because every time your PGs and my PG, their camera is on. I can see both the PGs in the conference hall. I can see your PGs. So many PGs, they put their camera on. I think they are learning nicely.
Yeah. And thank you so much to you. Okay.
Bahut acha. And Madhu Raju is very bright.
Thank you, madam.
We will be meeting you soon.
Yeah. I am looking forward to meeting you all in your state conference.
Yes. First, we will be meeting in the resort, and then we will be meeting in the conference.
Yes. Thank you, madam.
Thank you, Vivek Kedia, for helping the managing committee people, because we are the people who face the brunt of this AIOS headquarters, and now Dr. Kashyap is traveling, I think today or tomorrow, for the MC meeting.
Tomorrow.
Ask the directory. They will ask the directory. They will ask the activity report. So, Dr. Madhu, you have sent your activity report from Andhra.
Yes, madam.
So, from July to January.
Yes, madam. July to January.
So, all webinars and activity, these
webinars, ARC programs, social awareness programs, madam.
Social awareness.
Yeah.
Sahab jagah se bhej rahe hain. But one thing is there, the chairman scientific committee can execute it. If the chairman scientific committee is not management committee, who will listen to the management committee person? Who will listen? And the management committee person is overburdened. He send me the report. Yeah. So nice. Okay, bye everyone.
Bye.
Bye, ma'am.
Thank you.
Thank you.
Bye, all the speakers. We are thankful. So I can see Dr. Nidhi. Yes, bye.
Okay, thank you.
Thank you, Todd. And thank you, Secretary. Thank you, Dr. BP Kashyap.
Thank you, sir.
You always spare time despite your busy OT, and he is traveling tomorrow. So I truly appreciate your gesture.
Thank you, madam. Thank you.
Thank